Hello, everyone. A warm welcome to today's ICS webinar, the fourth module of the Sleep Certification Course. And this module is going to be very, very interesting because it is going to talk about treatment of obstructive sleep apnea, whether it is PAP therapy or non-PAP therapy. And therefore, as you can imagine, today's webinar is going to be really practice changing. We are going to talk about everything that you need to know when you're dealing with your patients who have sleep apnea. So today will not be theory, but it will be very, very practical and experience related discussion and talks. And I'm very, very happy and proud to tell you all that today we have the best faculty in the entire country who's going to be actually enlightening us from their personal experience and their profound knowledge about how we should be going about treating our patients of sleep apnea. Before we start the webinar, I'd like to thank ICS Indian Chess Society. I'd like to thank Dr. J.K. Samaria, our president, Dr. Rajadhar, our secretary, and we have Dr. Rakesh Chawla and Dr. Shivani also with us, who are very much our ICS governing body. In fact, Dr. Rakesh Chawla is our president-elect. And over and above, I would really like to thank SIPLA, especially Hitesh, for helping us out, taking this wonderful knowledge to all of you all across the country. So I'd like to first invite our first speaker, Dr. Shivani. So Dr. Shivani requires no introduction whatsoever. We all know Dr. Shivani Swami. She's from Jaipur. She's the consultant pulmonologist at the Amar Jain Hospital. We are so proud of her. She's governing body member of our ICS. And at this young age, she has so many feathers in her cap. She has basically done her fellowship in sleep medicine, the ISDA she has done. She is a fellow in interventional pulmonology. She's trained from UK and she is certified in allergy immunology. She is the secretary of Southeast Asian Academy of Sleep Medicine. She's a secretary of Sleep Education and Research Society, and she's actually authored a textbook on sleep-related breathing disorders, in addition to authoring so many other publications. So, with this brief introduction, I would like to now invite Dr. Shivani Swami, and I know she's going to give her words of wisdom to us, which will be absolutely useful to us for our practice in sleep medicine. Over to you, Shivani.
Thank you, ma'am. At the outset, I would really like to thank you for the very kind introduction and also for inviting me to be here. I am very sure that I'm going to really learn a lot myself today evening with such august panelists that I'm sharing the panel with. So, with that, I will go on to speaking about my talk, which is on PAP therapy. I'll just like to, can I start sharing my, yeah.
Sure.
Give me 1 second, please. I'll just. So, is my screen visible now?
Yes, we can see your screen. Yes.
So, I am talking on treatment of OSA with PAP therapy. I think in the past few lectures and modules that have been so wonderfully curated, we have all learned about sleep apnea, what are the symptoms, and then how do we go about diagnosing it. But the challenge, of course, remains in every stream of medicine is therapeutics. So sleep apnea is especially more challenging because definitely we know that the gold standard of treatment is actually something which has very poor compliance and adherence. However, what do the guidelines say? So there is this American Academy of Sleep Medicine guidelines which were published in 2019. So once you diagnose the patient with sleep apnea, we must actually keep in mind whether the patient has symptoms which include excessive daytime sleepiness or reduced sleep-related quality of life, that may be snoring, witnessed apneas, disturbed nighttime sleep, or the other comorbidities that the patient has. Once you've ascertained the treatment, you know his comorbidities and his functional status, please discuss the treatment options with the patient for sleep apnea. Of course, the gold standard of treatment till date remains PAP therapy. However, there would be a subset of patients who may not actually be willing for PAP therapy. So, what do you do in these patients? So, basically, for those patients, we move on to sometimes selected non-PAP therapy, which Chawla sir would be discussing. But my topic today is PAP therapy. So which basically comes into role if the patient has moderate to severe sleep apnea or and has significant comorbidities. So consider initiating PAP therapy. So these are the American guidelines, but if you ask me today, I would say that the in-lab manual titration, which is a level 1 titration study, still remains the gold standard of therapeutic choices and PAP therapy titration till date. So it is actually quite important that you do therapeutic titration in lab for these patients, and only based on that can we actually give them the choices of therapy. It's extremely important that we also ascertain that what is the right interface for them, which would need not just mask fitting, but also asking the patient if they have nasal congestion, if they have claustrophobia, or if they are mouth breathers. And sometimes you also have to ascertain if the patient lives in a dry state, wherein if they would need humidification or not. So, in a state like ours, which is quite dry, we most often use humidifiers. But however, if the patient is in a coastal humid region, they may not actually need humidifiers. Certainly, these are patients wherein you would have to spend a lot of time with them. You will have to explain to them what the intervention does, and definitely what are the side effects if they do not actually end up using PAP therapy. Sometimes you have to follow them up very closely. And the newest kid on the block, which is telemonitoring, actually is found to increase adherence and compliance. But what exactly is PAP therapy? It's just basically an equipment which has various components, which includes an interface, a connecting tubing, which is, of course, of various types as well, and then the equipment itself. So, this is what it compiles. But we do know that there are various types, and which one to use in which patient is actually the most challenging part, choosing the right device. Of course, there is the CPAP, which is the manual CPAP, also called the uh, and then there is the auto CPAP, which is also called as the APAP, or then bilevel or auto bilevel. So, which to use in which patient is a very carefully titrated device. And like we always used to see, like to say that these are actually tailor-made therapies. There is no one size fits all. And this tailor-made therapy is on various levels, not only just on the device, but also in the interface, whether the patient needs humidification, then whether the patient needs cloud connectivity, because if they would need very closely remotely monitoring, then cloud connectivity is genuinely extremely helpful, wherein not only can you see the usage or what is actually going on, how much is the pressure, how much is the leak, but if you need to make small changes in the pressure or in the settings of the equipment, you could actually do it from the comfort of your office. Noise levels of the equipment is usually not much of a concern to the patient, but very often are a huge concern to the bed partner. Especially with the newer equipment, the noise levels, although are not much, but if the patient has mask leaks, huge mask leak, then it becomes a matter of a concern. We also need to ascertain if the patient is a frequent traveler, in which case sometimes they may actually need to buy even a portable device. So these are things that we must really keep in mind. But the most important in our country till date remains finance, because the patient will invariably paying out of their own pocket. There are hardly any policies or any covers that are covering sleep disorders. So that definitely remains a challenge and a major cause for ascertaining what kind of device can the patient actually afford, that would also help him in treating the disorder but not burn a hole in his pocket. So, positive airway pressure, what exactly is it? It is a very simple device which was described first by Professor Sullivan in 1981 in a publication in the journal Lancet. It basically just works as an air splint to maintain the upper airway patency during sleep. And the invention of CPAP was actually very interesting. Professor Sullivan actually invented it to treat his pug dogs snoring, and that is how it actually came into. And he used a basic vacuum cleaner to make the first CPAP. So that is how it came into being. And till date, after over 4 decades, it still remains the most effective non invasive form of therapy for obstructive sleep apnea. And of course, we've come a long way in so many decades. We've gone from, the CPAP to auto-PAP to a bi-level, auto-bi-level, and even further. So these are the different types of PAP therapy, but each one has a very specific role. What does a continuous positive air pressure or a CPAP or a manual CPAP do? It basically delivers a constant set pressure throughout the night, both during inhalation and exhalation, and there are absolutely no changes that the equipment makes for any airflow obstruction or any transitions in the sleep stages. That is what it basically does. But when we look at the auto PAP or the auto CPAP, that delivers a varied pressure throughout the night. However, the what this equipment basically does is the algorithm is set in a way that it reads the airflow limitation, and depending upon the patency of the upper airway, it increases or reduces the pressure. It is often considered more comfortable because the pressure delivery is changing dynamically as the patient's airflow obstruction is changing with the individual needs. So what it does is, of course, when there is a respiratory event, it increases pressure. When there is no event, it gradually starts reducing the pressure, and hence it's considered more comfortable. However, there is a certain subset of patients who would actually require auto CPAP, and it is not for everybody. So those patients usually are people who have positional or REM related OSA because they have varied pressure requirements during the night. Patients who require very high pressures, wherein you would probably not need that high pressure right from the beginning of sleep. And then, of course, there are patients who occasionally drink because on nights that they do consume alcohol, their pressure requirements are going to be higher. There is a very soft indication of doing titration studies, but that again is not gold standard. The patients have to be very carefully selected and definitely not something that we recommend offhand. Then going on to the bi-level devices or the NIVs. It has a higher pressure on inhalation or lower pressure on exhalation, with the minimum difference being at least 4 centimeter of water. There are various patients for which a bi-level is advised. However, again, this can only be achieved after we've done a manual titration and we found that the patient has been non-tolerant to PAP therapy in terms of CPAP or auto CPAP because of very high pressures, or patients who have overlapping COPD and OSA, patients who have nocturnal hyperventilation syndrome, patients who have restrictive lung diseases, or very often patients who have central sleep apnea, wherein we may need to actually give them a backup rate. Then there is auto bi-level device. Of course, there is a pressure support on inhalation and a lower pressure on exhalation. Although the pressure range is varied in an auto bi-level device, it can be used on multiple types of patients. Of course, those who are non-tolerant to CPAP or auto CPAP patients who also have concomitant heart failure or obesity hyperventilation, but definitely not indicated in patients with an overlap of OSA and COPD or lung diseases, because in these patients, it may actually sometimes lead to hyperinflation of the lungs. So that is a word of caution that we must really practice, because maybe a lot of our patients may actually be suffering from this overlap. Then coming to choosing the right interface. So it's not just about type of the mask, it is also about size of the mask. If you use the correct mask in an incorrect size for the same patient, it actually is still going to lead you to have high mask leak. We also need to ask them if they are mouth breathers. So if they are mouth breathers and you give them a nasal mask or a nasal pillow, it was not going to suffice, but also ensure that they're not claustrophobic, because if you give a oronasal mask to somebody who's claustrophobic, then that's something that they will also not tolerate. So there are people who are claustrophobic and are mouth breathers. So maybe you could just use a nasal mask or a nasal pillow with a chin strap for these patients. And that is how you work around. So it's extremely important that when the patient is about to undergo a titration study, the technician or the doctor spends some time with the patient and makes sure that the size is adequate for the patient, appropriate, and also that it is comfortable for the patient. Now, as we go ahead, we are not only at the full face mask or the oronasal mask, there is also the nasal mask, nasal pillow, but there are also now masks which are actually oronasal masks, but they don't start from the bridge of the nose. They start from here, right below the nose, and go up to the lower level of the lower lip of it around the chin. So these we have now varied levels of varied types of mask, and definitely even the nasal mask have come to a point wherein they're slightly bigger than the nasal pillows, like the one that you see here. So definitely a lot of these features are adding comfort to the patient in terms of interface, because that's an important part of therapy. But even after we've started patients on PAP therapy, there are various challenges that we face invariably, which could be mask leaks, mouth leaks, dryness, difficulty exhaling, and definitely compliance still remains a challenge. So, what do you do when you see these patients with such challenges? If there is a mask leak, make sure that the fit is right. If the patient is a mouth breather and we have by mistake given them a nasal mask and we did not realize, and neither did they tell us that they're mouth breathers, then we could just maybe add a chin strap. If they're still facing excessive dryness, then make sure that they have climate controlled tubing and, of course, a humidifier if necessary. If they face rhinitis or congestion, then sometimes you may actually need to add a nasal decongestant. If they still have poor understanding or motivation, spend some time, understand their problems, challenges, explain to them. More often than not, these patients will actually comply really well to these small interventions. If the patient still finds it very difficult to exhale against the pressure, then maybe sometimes you could just add an expiratory pressure relief, which would vary between 1 to 3 centimeter, even in a CPAP, which would reduce the pressure by in that much centimeter and make it more comfortable for the patient to exhale against the high pressure. If these patients find it difficult to fall asleep, of course, if it is because of high pressures, you need to add ramp, which could vary between 0 to 45 minutes, which ensures that the pressure starts increasing after the patient has slept. And there is now also auto ramp, wherein the machine is actually going to detect that the patient has slept and only then start increasing the pressure. So these are all things and small interventions which could actually improve the compliance, add to the comfort of the patient, but at the same time, maybe initially call the patient at 4 to 6 weeks with the compliance data, see how they're doing, understand if they're facing any challenges, and then maybe on a second visit after 6 months. So these all things are small interventions which will go a long way in increasing compliance, and hence we must actually take care of these. Now, here I would like to spend a few minutes. I have saved these slides for the last because titration protocol is actually the backbone of therapy. So, if you've done a manual titration well, that is going to go again a long way because the patient is going to find it more comfortable. Of course, he might actually just do with a lower cost basic CPAP rather than switching to a high end equipment like a auto CPAP, and that expense saved is going to also obviously help the patient in terms of buying the equipment. So what you do once you explain to the patient what the procedure is going to be, you sometimes actually even tell them to just put on the mask during the day for some time with this, try the machine on so that they get used to it. But on the night of the titration study, the technician or the doctor starts with a minimum pressure of 4 centimeters of water on a manual CPAP with an interface which is comfortable to the patient. And then they observe that once the patient has slept, so if they have more than 2 obstructive apneas, more than 3 hypoapneas, more than 5 respiratory event related arousals, or more than 3 minutes of loud snoring, then they increase the pressure by 1 centimeter every 5 minutes until these events are actually eliminated. Once these events are eliminated for at least 30 minutes of sleep, which should include at least 15 minutes of supine REM sleep, then they could actually go on exploring the pressure, which is increasing the pressure. But the exploration at this point is only going to be a maximum of 5 centimeters of water. So if the patient during this increasing of pressure awakens or feels uncomfortable, then we start reducing the pressure further. And that reduction has to be around 1 centimeter of water every 10 minutes. And we watch for the patient's breathing pattern. If there is reemergence of events like we had discussed, then of course we increase the pressure again. So this is the typical way wherein we find out what is the ideal pressure for the patient to stabilize his respiratory events and of course also prevent respiratory event related arousals. The recommended maximum pressure today on a CPAP is around 20 centimeters of water. You could, you have should add a expiratory pressure relief with this kind of a pressure. And sometimes the patients are actually not able to tolerate over 16 to 17 centimeters of pressure. So, like I had mentioned earlier, that there is no one size fits all. Sometimes it has to be tailor made. So, if your patient is uncomfortable at 15, 16 centimeters of water, then this equipment is not for him. And then this particular subset of patients are the ones wherein you would have to maybe titrate with a BiPAP. I would also briefly like to discuss the BiPAP titration. So, if your subject is for a BiPAP, then again, in the middle of the night, you switch over to a BiPAP with a minimum IPAP of 8, a minimum EPAP of 4, and you increase the EPAP and IPAP both by 1 centimeter of water for apneas. And if there are other events like hypoapneas, RERAs, or snoring, just increase the IPAP by 1 centimeter. And we follow the same protocol that we look for these events every 5 minutes until these events are eliminated for at least 30 minutes without events, with at least 15 minutes of supine REM sleep. Again, exploration of IPAP is another thing that we actually practice in BiPAP as well, but not with EPAP, only with the IPAP. The recommended maximum IPAP is 30 centimeters of water, which believe me is actually quite high. And then, of course, if the patient is uncomfortable at a higher pressure, you start reducing the pressure every 10 minutes until there is either reemergence of breathing events or snoring. So this is what I had to say about PAP therapy. And I'll hand it over back to Amita ma'am with again a huge vote of thanks for having me here. Thank you, ma'am.
Yeah, Shivani, thank you so much. This has been one of the best talks I've heard on CPAP. This was just so clear, lucid, precise, and extremely enlightening, in which every aspect of PAP therapy has been covered, whether it was how to initiate, or how to titrate, or how to troubleshoot, or how to make the most of it. Thank you so much, Shivani, for this completely comprehensive, very lucid overview about management of OSA with PAP therapy. Thank you once again.
Thank you, ma'am.
After this, now I would like to actually take a big turn by 360 degrees. And now we want to talk about treatment of OSA with non-PAP therapy. And I personally feel it's extremely important for us pulmonologists to know this very, very well, because we are always taught about PAP and we don't know about non-PAP therapy. And often our patients are not able to tolerate PAP therapy. And that therefore we know what more can be done for our patients. And for this, who else? None other than our very own extremely brilliant, extremely passionate, extremely popular Dr. Rakesh Chawla. I'm just so very happy to invite Dr. Rakesh Chawla to enlighten us about this very interesting aspect of sleep apnea, which is treatment with non-PAP therapy. I'm sure he, in his inimitable style, is going to tell us about in what way we can help our patient better. Dr. Rakesh Chawla requires no introduction whatsoever, which is as a formality. I would just like to tell you all that he is the president-elect of Indian Chair Society. He is the chairman Department of Respiratory Medicine and EBUS program at the Jaipur Golden Hospital and the Saroj Super Specialty Hospital, Delhi. He's also the president-elect of IAB, Indian Association for Bronchology. So I feel that currently he's the most important and the most powerful man in pulmonology in our country, president-elect of the two most important associations. He is a member board of regions of BOBIP, which is amazing. He was the organizing chairman of the very successful NAPCON 2023 Delhi, recipient of prestigious Dr. A. Pentil and Dr. R.C. Jain oration, recipients of so many orations, and he has achieved just so many things and received so many accolades and awards. I think if I keep on talking about him, it'll be tomorrow morning and I'll still be talking. So I shall cut short the introduction, and I would like to invite our own very Dr. Rakesh Chawla. Over to you, sir. Dr.
Thank
Chawla?
you, Amita. Hello, I'm audible.
Yes, sir.
Thank you, Amita, for a kind introduction. Thank you, my fellow colleagues, for today's webinar. Thank you, ICS and IAB, for having me with all of you. Well, I will start because I was trained with Colin Sullivan way back in 1996. The experience is full of, because when I am giving you the talk, you are going to have my experiences in between. Bear with me and enjoy the talk. Do not laugh at VIPs who nod off in the meetings or kids caught napping in the class. You will realize the importance of sleep medicine. They could be suffering from serious sleep disorders. Snore is more than an acoustic nuisance. Sleep and watchfulness, both of them, when immoderate, they constitute disease. You have seen these cartoons, and they are very helpful for at least the bed partners to understand. Blessings on him who invented sleep. It makes a shepherd equal to monarch, and the fool to the wise. There is one evil in this. It resembles death, since between a dead man and a sleeping man there is but little difference. Hello? How? What should I do?
Slide share. Can you slide share, sir, please?
I share on this 1 minute. This is my PowerPoint. Acha, okay. Where is the share? Here. I share. It's okay now?
Yes, yes. So, sir, now we will start your time now. We will not count the earlier part. So, sir, in 15 minutes,
You dare to look after me. I am very thankful.
Yes, sir.
For your kind words. Thank you.
Yes, sir. Yes, sir.
So, let's continue. Probably the most important things and advances in history of sleep medicine was the discovery of sleep apnea in 1965. Prior to 1980, the only effective treatment was tracheostomy. The introduction of CPAP through a nasal mask in 1981 marked another important discovery that fueled interest in sleep medicine practice and research. You have heard very nice talk by Dr. Shivani, and she has added on the beautiful part ending her presentation of how to titrate CPAP and how to titrate BiPAP. They are beautiful slides, Shivani. I have appreciated them. So you know this cartoon, and you know the sleep-related disorders are a group of illnesses with marked effects on patients' quality of life. They ignored their problem. Bapil Harry, we all knew he has sleep apnea, but he always ignored his issues. Why is sleep important? People who sleep more than 7 hours are healthier and live long. Those who sleep less than 7 hours, what are the benefits? Allows cells to heal, boosts immune system, rests the heart and cardiovascular system. Changes in sleep in different body systems. It helps you to rejuvenate central nervous system, cardiovascular, respiratory, GI, endocrine. Quality, quantity, and timing are the dimensions of sleep. from 52 to 104 million in 2003, and now it must be definitely 110 million or more. What if CPAP magic box fails? What is the answer? It is non-CPAP therapy. So I will focus after finishing of Dr. Shivani, what is beyond CPAP? We will be discussing, Amita will be discussing how when patient doesn't accept the CPAP or what are the reasons of not accepting CPAP. So what are the common reasons for CPAP intolerance and how can these be addressed with other treatments? Common causes of intolerance are discomfort from the mask or device. Patient has got an ill-fitting mask, skin irritation, or he gets a hair leak. Pressure intolerance, the pressures are too high or pressures are too low. If you have done manual titration, I am sure pressure intolerance is gone. With the APAP, sometimes during the events in sleep, the pressure suddenly goes high. Maybe that is not a routine for the patient, but it happens and gives discomfort to the patient. Nasal congestion or dryness. So using of humidifiers, noises from the machine. We have these days the smart, soundless machines with smart algorithms, psychological barriers, stigma, claustrophobia, or the wife will come and say, I do not want my husband with hose pipe in bed looking like Ganesh. This is an experience which I am telling you is not in the literature, but wife says this, that I cannot see him like this in the bed. Poor adherence or motivation, financial barriers. CPAP is ineffective for central or mixed sleep apnea. So your polysomnography, when you do attend it, you have to be very careful looking for central or mixed sleep apneas where there are other equipments which will be offered. Which patient population alternative therapies are most appropriate? Patients with mild to moderate OSA, patient intolerant to CPAP, patient with positional obstructive sleep apnea, obese patients with anatomical abnormalities, patients with central sleep apnea, pediatric patients or elderly patients. You have answers if there is no acceptability of CPAP or patients are intolerant to CPAP. What are these non-CPAP therapies to treat OSA? We have non-surgical and we have the surgical management. In non-surgical, there are Provent, oral appliances, positional therapies, weight loss, lifestyle changes. And new therapies are emerging like Excite OSA, pharmacological therapies, and lifestyle modification. Surgery, there are plethora of surgeries, but uvulopalatopharyngoplasty is the commonest performed surgery. DICE is picking up a good importance in justifying the airway, which level of surgery should be done. What is a Provent sleep apnea therapy? These are the disposable nasal stickers with filters which are working one way. So you are not able to exhale and the pressure is generated to keep your airway open. It is a disposable night use nasal device. You use it on the nostrils. It's a proprietary micro well design, small, disposable, making it discreet and very convenient. Like your contact lenses, you have to change it every night. It decreases apnea, reduces daytime sleepiness, improves quality of life, reduces the snoring, and it's not very expensive. If patient has got respiratory muscle weaknesses or has got a bullous lung disease or pneumothorax or pneumomediate sternum, because I told you when you exhale, the pressure is built up back to keep the airways open. It may have an adverse effect if the patient has got end-stage COPD or he has got a pneumothorax, so that the leaks and the problems should not happen. Or acute respiratory infections or severe heart disease, the device is contraindicated. Now comes the positional sleep apnea. Does tennis ball help? Positional sleep apnea is a subtype of obstructive sleep apnea. You can say phenotype of OSA. There is a targeted intervention aimed at preventing the supine sleep. You get maximum events when the patient is supine. The moment it changes to the left lateral position or the right lateral position, that reduces the apnea events. And if you ask typically the patient of sleep apnea or a heavy snorer, you know it that he needs two pillows. He wants to put his arm under his head or her head and take a turn and go to sleep. Straight they cannot. They know they feel suffocated. So here where is a positional therapy will help if they are not accepting CPAP. So there are positional sleep aids, wearable devices that prevent supine sleep. You have positional pillows, there are vibrating positional devices. You have behavioral interventions that training of the patient to learn to sleep if you don't want any of these devices. So tennis ball, yes, 10 rupees therapy. Here where we need to be honest when you are picking the patient for polysomnography or you are doing the level 3 study. You must tell the patient that end of the day after doing this, you will need a CPAP. Can you afford polysomnography or the level 3 sleep studies? You may need a CPAP which will cost you 25,000 rupees to anywhere 81,000 rupees. Can you afford that? If he says yes, please go ahead with PSG or level 3 sleep studies, whatever you have. If he says no, I cannot buy CPAP, please give him 10 rupees tennis ball treatment. Get that stitched either in pajama or in the back of the shirt and give him a positional sleep therapy. Electronic tennis ball, another beautiful equipment available in 10,000 or 11,000 rupees. It's a night shift sleep positioner. It is beautiful. If you put it on the back of the neck like this, it will be here and there is a silicone belt and you have the magnetic joints here so that there is no suffocation. If there is a stretching, it opens up. And it gives you vibrations the moment sleep apnea and the events are happening till you wake up or you change your position. It will keep on vibrating. Once you change, it will stop. So adjustable neck strap is made of silicone. Buckle functions with a quick release magnet, ensuring you cannot be trapped. The night shift technology perfectly times the vibration to occur immediately after you shift the position. This is how it looks like. These are two magnetic buttons. This is the charging cable and the download data port, and you use it. It is a wonderful equipment. If you suffer from mild to moderate sleep apnea, night shift is a simple solution which seems like to look after this problem. This is a data you download, getting a software when you are buying this kind of a data that you are using number of hours of sleep, when you get the disturbance, how many times you have changed the position, all information is there. Another recent arrival is Excite OSA. We know these are the intrinsic, extrinsic muscles of the tongue, genioglossus, hypoglossus, palatoglossus, styloglossus. And this is the microscopic picture of these muscles. What this does, the tongue muscles lose their endurance in response to stimulation in OSA due to aging or lifestyle problems. The endurance is decreased. This device will increase the endurance, and a method so that the upper airway dilatory muscles will be working finally and the tongue will be moving forward, increasing the air space posteriorly. It has to be used 20 minutes only each day for 6 weeks, and the claim is that endurance of the tongue muscles, which falls back during the sleep, is gained by this. This is how the machine looks like, and this is how it works. If you see it beautifully, 20 minutes you have to use it before sleep for continuously 6 weeks, and the claim is fantastic. Soft silicone devices, again, same way as the Provent sleep apnea therapy works. These two balls which are visible goes to the nostrils and work one way, and you are able to keep your airways open. Oral appliances are very, very popular now with mandibular repositioning devices and tongue retaining devices. They are FDA approved, and USA has approved them. and they're very popular in USA. In our country, still the dentists who are designing are getting into the sleep apnea treatment, but over the counter or things, I am not aware if they are available. Indicated are retroganthic patients, mild to moderate OSA, patients who failed or refused other treatment, and who are medically compromised. So various devices are there, from mandibular positioning device to mandibular advanced appliances. There are local appliances which you can apply in your tongue. They work by increasing the airway. They pull the genioglossus forward, pull the tongue forward, upper airway space is regained, snoring and OSA is eliminated. These are the various mandibular advancement devices which are available. These are the various tongue retaining devices. They hold the tongue primarily, and in sleep it doesn't fall back. Another popular, surgical management. Surgery may be as a primary treatment of option in patients who have the obstructive reason. So whenever there is a patient of sleep for screening, you are doing two things important. Asking him to get the thyroid function test done, which are the causes of apnea and snoring. Thyroid function is normal. Patient goes for ENT checkup to rule out any nasal or the oral obstruction. If those anatomical causes are treatable, I think ENT person is the choice to help you to solve the problem of sleep apnea and snoring. So, as I said, drug-induced sleep endoscopy, a very, very important aspect to see during sleep the levels of obstruction and where to operate. And the beauty is now, if we are not able to interpret artificial intelligence, when you submit this video, tells you very nicely which is the level of obstruction and where to operate. So various surgical procedures for nasal cavity are polypectomy, polypectomy and ablation of the turbinates. Nasopharynx, you have adenoidectomy. Oropharynx, you have tonsillectomy, UPP. For hypopharynx, you have midline glossectomy. Oro and hypopharynx, you have maxillomandibular advancement. Surgery, as is not fit for all, you have to tailor-made. DICE is there to help you to select the site of surgery. Minimally invasive surgical intervention is the hypoglossal nerve stimulation. It is like a pacemaker, non-continuous therapy. You switch it on during the sleep in the night or in the evening when you are going to sleep. Adherence rate is very high. Lifestyle disruption is minimum, and you are using it like a pacemaker, infraclavicular area, and you are putting the electrodes into the base of the tongue, and you switch it on when you are going to sleep. Whenever your posterior space is getting blocked, you are getting snoring and apneas, it gets stimulated, the tongue gets stimulated, it moves forward, and the apneas and the snoring disappear. This is how you expose the tongue muscles and put the electrodes in this. There is a beautiful study of 12 months outcome, and it reduces the upper airway muscle activity during sleep. Is a key contributor, we know. Hypoglossal nerve stimulation activates upper airway dilator muscles, including genioglossus, and has the potential to reduce obstructive sleep apnea. Follow-up of 12 months is got a very positive report. What is maxillomandibular advancement? These are the complicated surgeries. I am sure we pulmonologists do not advocate, do not send it, but they are being done in the world for severe disease, failure with a more conservative measures. Mid-face, palate and mandibles are advanced anteriorly. Have a look how it is done. It's beautiful to see the video and get an idea what they do with maxillomandibular advancement. This is the posterior space, which is a constricted airway. And once the surgery is done, after putting the braces on the teeth, doing the surgery of the mandible, advancing the mandible, and fixing this area and increasing the posterior space. I'm sure it is a very complicated surgery where various screws and things are done to increase the posterior airway space. How many of you will recommend? It's very difficult for me. And this is how the posterior air space is increased and the patient is better with this advancement. We know rhinological procedures, ENT people are doing it. If you see the endoscopic DNS correction, so they will remove the septa to make your nose bridge straight, increasing the space in the nostril to have a good flow of air. Another is your tonsillectomy. You do to remove the obstruction from the oropharynx, and the tonsils are removed to remove the obstruction, especially in children with the pediatric sleep apnea. Another is the adenoidectomy. Again, a very common procedure for children. When the posterior pharynx, you are going to remove this lymphoid tissue. The adenoids are removed to increase and remove the obstruction. Very common procedure, uvulopalatopharyngoplasty. It is introduced by Fujila, the most frequently performed surgical procedure for snoring. This is the procedure where DICE is going to help you a lot. How it is done, just see the uvula, the part of the palate is removed to increase the airspace so that the apneas, snoring disappears. Now, if UPP fails, then what? Back to CPAP. Now, when you are again asking the patient for CPAP, you have increased the leak inside. So, UPP has to be done very methodically and very experienced person. Just see the video how they do the uvulopalatopharyngoplasty. This is laser assisted where they remove all these areas. I will just make it forward. They burn this area with the lasers, and you can see the real picture how this happens. And then they remove the another part of the palate and they remove the uvula. And once they remove the uvula, you see how the space is increased. Tongue-based suspension and reduction, sutures attached to screw at the inner mandible. You see the inner mandible, it is done and place the wire into the tongue to pull it back so that a lung collapse should not happen. You are putting the radio frequency generated into the tongue again to make the muscles dry and pull the space ahead. You see how the tongue-based reduction is done. The pillars, they are placed, you see now, posteriorly. You place these materials and your posterior, the tongue retracts back and your space is increased. Placement of implants into the tongue, you see how they place. They are claiming it to be the OPD procedure done under conscious sedation with good anesthesia, and you are placing these implants. Again, it will contract, the airspace gets increased. Radio frequency ablations again are done through these. You put your radio frequency probe into this part of the palate that you are releasing the radio frequency waves to again leading to fibrosis and increasing the space. Another same way, the different kind of probes. You have genioglossus advancement, osteotomy of anterior mandible with advancement and rotation of the prevent the retraction to increase the space. Hyoid suspension, the same. Tracheostomy, you are bypassing the whole structure which we are talking, there is no need of anything. Patient is well, there are no apneas, there are no snoring, you have a tracheostomy, but the quality of life, that is what has changed in 1981 when the CPAP was. Bariatric surgery. It is like a storm, the GI surgeon are taking it. So for a pulmonologist, we know the big patients and big risks and big expectations, lowest mortality if BMI is less than 25, highest mortality if it is more than 40 kg per square meter. We know the medical complications of obesity. Why we want to operate is a big health risk: hypertension, cancer, gallbladder, renal failure, stroke, various diseases. So you want a good results, at least 50% of excess weight, low operative morbidity, should be well tolerated, no complications, the goal of surgery. It is said then done. Good data are produced, but what happens, the complications of bariatric surgery, I have not seen people talking. Various procedures are restrictive, malabsorptive, hybrid. Just see viewers how this gastric bending is done, how vertical bended gastroplasty is done. Balloons are available. You put these balloons through the endoscope into the stomach. It takes the space. Your appetite is reduced, and sometimes these balloons rupture inside, but they say they stay, they reduce the appetite and helps in reduction of the weight. My question is again to them is the maintenance obesity. Once you can never be normal in life, you have to have all lifestyle modification to practice. Biliopancreatic diversion, Roux-en-Y gastric bypass, which is the commonest, which is done. So they work by reducing of the appetite, restriction, malabsorption, alimentary limb. So there are so many things which happen. These
Sir,
are
can you
various.
wind up, sir? Can you wind up okay.
I am just coming down quickly to move ahead, Amita.
Okay.
Lifestyle modifications are very important. We know they help. There is an instrument which helps you to increase the airway muscle strength, various weight loss strategies. Beautiful drug which has come is Mounjaro after the Ozempic, sitagliptin. The celebrities are taking it and they are using it, but still pulmonologists have got a limited experience. The various trials, the drug is already approved by FDA. There are other pharmacological agents which are approved by FDA, and current therapies are available. Artificial intelligence is helping in diagnosing and personalizing the OSA. Time is not far that the AI is going to steer the treatment of OSA in coming 10 years. There is a beautiful paper on non-CPAP therapies for OSA. There is a message with our Prime Minister and the community. They are sending.
हाल ही में
Right.
मोटापे की समस्या पर भारतीय मोटेपन ओबेसिटी ये कितना बड़ा
Let's wind up now, sir, please.
को टालने का प्रयास करना ही होगा। सर्वे संतु निरामय, सब सुखी हो, सब निरामय, सर्वे भक्ति।
Next decade is going to bring a significant advancement in management of sleep apnea. CPAP is still the gold standard. Clinical success of CPAP is limited due to intolerance and less compliance. Future use of high technology, upper airway models, CT, DISC is going to help to the thing. Well, the wife always says, why you did not bring the silencer in the bed and why you did not think of CPAP. 80% people have simple sleep apnea, and I'm sure CPAP remains the choice even today. So sleep better, feel better, and increase your energy. Thank you. Thank you very much.
Thank you. Thank you so very much, Dr. Chawla. I think this was absolutely fantastic. I mean, I found this talk so interesting and so exciting. And I kind of feel that actually it is not always PAP therapy. And there is so much more that we have to offer to our patients. And often we are actually resisting and restricting our ourselves from prescribing it. So thank you so much. I think you've just completed everything that anybody needs to really know about non-PAP therapy. And I think it was very, very visual. It was very, very entertaining. And it was absolutely extremely lucid and comprehensive. Thank you very, very much for this fantastic talk. Now I'd like to invite our very, very esteemed, absolutely brilliant, extremely accomplished panelists who I'm so happy who agreed to be on board with us. So I would like to first introduce Dr. Tampi, my very, very dear friend. Dr. Tampi is somebody who I respect as a pulmonologist, and I absolutely adore him as the most wonderful friend. He is a great achiever. Can we have the CV of Dr. Tampi, please? The previous one. Yes, great. So again, Dr. Tampi, the whole world knows him. He doesn't require any introduction at all. So he's basically done his MD medicine and he's done his DM pulmonary. He's from AFMC, he's from the Army, the Navy, and he's our man. He has been the former professor and senior advisor in the Indian Armed Forces. He was the former honorary faculty and Unit 5 head at the GMC and JJ Hospital, former UG and PG teacher in Maharashtra University Health Sciences. He's a current DNB teacher and examiner with the DNB. He is extremely experienced in diving physiology and hyperbaric oxygen therapy, in addition to knowing everything about pulmonology. Numerous publications, national, international, written several textbook chapters, and he's recipient of the Rajnanda Pulmonary Disease Research Fellowship in the UK. Currently, he is a senior consultant pulmonologist and physician at Bombay Hospital. He's my colleague. I'm so proud of having him. He's always there for us, always advising, always supporting, and always leading the way. So welcome, Dr. Tampi.
Thank you, man, for the great introduction.
I'd like to now invite Dr. Nithya Haridas, again, a very, very bright and a brilliant pulmonologist from Kochi. She is the Associate Professor at the Department of Respiratory Medicine at AIIMS Kochi. The Amrita Sciences Kochi. She was a Souvenir Committee Chairman of Pulmocon 2024 Kochi, Organizing Secretary of Workshop on Thoracoscopy, and which was done at the Amrita Kochi. She has done her certification in International Sleep Disorder, which was by World Sleep Society. Chancellor's Publication Excellence Award in AIRA 2024. That's brilliant, Dr. Nithya. Thrilled to know this about you. And she's also certified in allergy and immunology. And she has more than 35 national and international publications in textbook and otherwise in the journals. So we are so very happy to invite the very accomplished young Dr. Nithya Haridas with us, who's quite, and her passion is...
Thank you, ma'am. Thank you for those kind words, ma'am.
Welcome. And now I'm going to introduce my very favorite, none other than Dr. Shyam Krishnan. First of all, I would like everybody to know that it's his birthday today. So very happy birthday, Dr. Shyam. And we are so grateful to you to, accept and continue with your commitment, which you made when you were not aware when the webinar, which date it was. So thank you so much for being so sincere and for always supporting us.
Thank
so
you.
Dr. Shyam again requires no introduction whatsoever. He's one of the young, bright pulmonologists who we are so proud about. He is a lead consultant, interventional and clinical pulmonologist in the Department of Pulmonary Medicine at the CMRI Birla Hospital, Kolkata. He is the faculty for DNB Respiratory Medicine. At such a young age, he is also an entrepreneur and he's a co-founder of Bio Educational Initiative. He has more than 50 publications and book chapters, and his areas of interest is IP, which we all know. Whenever we have difficult patients, we always pack them off to Shyam. And ILD and OSA, OAD is also his passion, and artificial intelligence. So that's quite interesting. So a warm welcome, Shyam, to you.
Amita, Rajadhar is very proud of having him as his possession. He's very
proud and lucky. I'm jealous. I'm jealous of Dr. Rajadhar only about one thing, that he has Shyam and we don't have Shyam.
No,
Okay.
we'll be there for all of your initiatives. Don't worry.
Absolutely. You have no option. We'll just pull you with us, Okay, great. So with this brief introduction, can we just move the introduction slide, please? A tech team.
So now I think I am the proud of introducing this showstopper of the webinars. I am sure the webinars of the country are steered by Amita, and it will go down in history whenever somebody will write from the COVID time to till now, when every week everybody was doing COVID webinars. Now when it is physical conferences, physical webinars, what you say in a language की इसने ना झड़ी लगा दी है webinars की, बैठ ही नहीं सकती है. Wednesday webinar, Friday webinar, Thursday webinar, कौन कर रहा है? अमिता कर रही है. And how she does it, not that any webinar her energy is gone down or she is not serious or she will not send it to all medias. She will make it sure how the instructions are passed. Yesterday she had an 1 hour meeting when she is doing an e-bus workshop in Delhi. After that, again morning 4 a.m. there is a message with Vivek, and then she will be again up at 6 a.m. Oh, what you say, we salute you, Amita. Right. But I have to introduce you formally. She is program in charge and teacher DNB, MD and DNB examiner for pulmonology, awarded as legend in pulmonology by Health Minister, who is now the Science and Technology Minister, named a leading Indian woman pulmonologist, first to have the Board of Reagents placement as a woman in the country, author of more than 60 publications, secretary, not secretary, she should write it, dynamic honorary secretary of Indian Association of Oncology. You can match 25 years to 3 years of her secretaryship. Training Education Initiative, member Board of Reagents, West Zone chairperson of Thoracic Endoscopy Society, recipient of Young Achiever Award in the field of pulmonology. We are proud of you, Amita, to have, and I am also very proud to have you as a very close friend. Thank you, Amita. Please take over and move ahead the discussion.
Thank you so much for these kind words. I'm really touched and overwhelmed. And I must make a very honest confession today that, I just feel that every time we select the best faculty for our webinars, but this time, because I was supposed to be moderating, I have been, extra particular, and I'm just so proud of each and every faculty we have on board today. Each of them is a great achiever and is going to contribute huge amount of knowledge to each of us about sleep medicine and treatment of OSA. I just want to again thank Dr. Shivani and Dr. Rakesh Chawla for the most fabulous talks, because our job has become just so easy. And I'm so looking forward to listening to Dr. Tampi, Dr. Nithya, and Dr. Shyam, who's going to be giving us all the wise words of wisdom, and they're going to make us much, much better in practice of sleep medicine. So many of the things and most of the things are covered already in the talks. But basically, we feel that when we listen, we remember. But when we discuss, we know it for life. So now we're going to discuss many of the things that have already been spoken about. So first question to my dear friend, Dr. Tampi. So, sir, can you please tell us that in which group of patients you will decide to treat their OSA, and which patients you will just observe? And if you decide that you are just going to observe them, then what advice will you give them?
Yeah, thank you, Dr. Amita, for the wonderful introduction. And when it comes to managing obstructive sleep apnea patients, the approach depends on the severity of the condition, symptoms, and other factors. So basically, when you treat OSA patients, if they have severe OSA, which is an AHI above 30, as all of us know, and they often require treatment, especially if they experience symptoms like excessive daytime sleepiness, snoring, or witnessed apneas. The second group is the symptomatic OSA patients who have an AHI, say, between 15 and 29, and who experience symptoms. They also may benefit from treatment. And then, of course, the high-risk patients with OSA who have underlying medical conditions like hypertension, cardiovascular diseases, or diabetes, or pulmonary diseases, which may require treatment to mitigate these risks. Now, that leaves us a small group of patients where we observe. For example, the mild OSA patients, as was referred to by Dr. Chawla very nicely. And these patients fall in an AHI below 15 without significant symptoms, and they may be observed with regular follow-up. Another group is the asymptomatic OSA who have OSA but do not have symptoms. These may also be monitored closely. Now, what advice would you give these patients who are kept under observation? That's the next step. Dr. Chawla had waxed eloquent about the non-positive airway pressure measures. So I will just emphasize what he had said, but I'll just group it under lifestyle modifications, monitoring and regular follow-up, and avoiding aggravating factors. So under lifestyle modifications, the weight loss is very important to encourage weight loss. If the patient is overweight or obese, this can help reduce the OSA severity. That's one major issue. It is often thought that a 10% reduction in weight can make a difference of almost 26-27% in the AHI. So it's well worth remembering that. To lose weight is very important. Exercise regularly. Physical activity can help improve sleep quality. We must avoid sedatives, sleeping pills, or other substances that can relax the airway muscles. The sleep position is very important. Encourage the patient to sleep on the side instead of the back to reduce snoring and apneas. Monitoring and follow up with regular checkups, and even encourage them to maintain a sleep diary to track their sleep patterns and symptoms. Of course, we need to avoid aggravating factors such as alcohol and tobacco. Both can worsen OSA, and we must be enthusiastic in managing the allergies, treat the allergies and colds promptly to reduce nasal congestion. By providing guidance on lifestyle modifications and monitoring patients under observation, this group of patients can be better manage their condition and potentially reduce the risk of progression to full-fledged treatment and positive airway pressure. Thank you.
That was just so fabulous. I mean, absolutely complete answer. I have nothing to add. So just quickly to say, if patients have severe sleep apnea, you have to treat them. If patient has moderate sleep apnea and if they are symptomatic or if they have comorbidities, you have to treat these patients. If the patients have mild sleep apnea and if they don't have symptoms, then you may observe them and you may advise everything that Dr. Tampi told us about. But please repeat, if you don't treat them, please repeat their sleep study after 6 months, and just make sure it's not worsening. That is very important. So thank you so much for also telling us about the follow-up. Great. Now I'd like to come to Dr. Nithya. So we all know that, we all love to prescribe PAP therapy and we know the best for sleep apnea treatment. So can you please tell us, how does PAP therapy reverse OSA?
So the role of this PAP therapy is almost related to the pathology of the pathophysiology of OSA. So when we consider the pathophysiology, one is the structure of the upper airway muscles, and the next thing would be the collapsibility. So here in the collapsibility, there's something of a concept known as peak width. That is the critical airway closure pressure. So the once it becomes more and more positive, the chance for airway collapsibility is increasing. So what we are doing with this PAP therapy, it is acting as a pneumatic splint. So what do you mean by this pneumatic splint? So how I explain to our patients is, suppose you have an airway which is completely obstructed, you'll be putting a stent instead of that. But here now you are having a problem where this obstruction or the collapse of airway is happening only during your sleep. So you need this stent only during your sleep. So it should be something which should be removable at other times. So for that, the best thing would be a positive airway pressure. So which would be acting just to keep your airways open. So that is the principle behind this positive airway pressure therapy, and it has various modes, like it can be a continuous or a bilateral.
Wonderful. I think this was just so nicely said. And I would like the way you're explaining to patients. I explain my patients different way. I basically tell them that, I'm inside the room and there is somebody outside the room. They want to come into the room. I don't want them to come in. So I close the door. But if there's no lock, then to prevent them from coming in, I have to close the door and I have to stand over there, giving pressure, not allowing the other person to come in. So if the other person who wants to come in will not break the door or do some surgery, they will just basically apply same pressure, equal pressure in opposite direction. They'll open the door and they'll come in. And similarly, we allow the air to go in. But I really liked your example. Maybe, I should start explaining this way. So that was fantastic. CPAP works as a pneumatic splint and it slits open the airway. That's wonderful. Now coming to Dr. Shyam. Happy birthday again, Shyam.
Thank you.
So if you decide to give PAP therapy to a patient, then how do you go about it?
So first and foremost is getting the patient to understand the equipment. You have to, him and the spouse or whomever he or she is sleeping with, getting them to understand the nuances of the machine, introducing it to them, choosing the mask, all telling them about the possible issues like the dryness of the nose, mouth, the importance of having a humidifier, uh, and kind of teaching the patient how so that he feels empowered to once you tell him about the machine, the initial concerns are he or she would be like, what if I had to go to the loo at the middle of the night? How do I disconnect it and reconnect it back? Do I have to wake up my partner just for that? So, first is choosing the machine, introducing the patient to the machine, whether it's a CPAP or auto BiPAP. So, like Dr. Shivani had said, first the titration is very important. You decide which PAP therapy, which PAP machine would be ideal for the patient. Then you counsel the patient about the machine, teach him how to use it, him or her, introduce him. If the patient has issues, claustrophobia, decide the interface you would want to recommend to the patient, be it nasal pillows, cushions, or the nasal mask or oronasal mask if he's a predominantly mouth breather. In patients who have issues adjusting to pressure, claustrophobia, you can try the daytime practice where he is using the mask during the daytime and doing other work so that he gets desensitized to the pressures. And then slowly, the first night, you can always tell him like 1 to 2 hours is good enough. Slowly build up on it. And probably within a 2-week period, you give him that 2-week period starting time. And slowly you need to initiate the concept of using the machine daily. And then the patient himself or herself would tell the benefits eventually.
Wonderful. You completed, right? I didn't interrupt.
Yeah.
No, this was wonderful. And I'm very, very happy about one point that you mentioned, which I was thinking I might be able to add, but I don't have to. So the thing is that, even before we do titration, we actually give the patient a 2-hour afternoon trial. They are sitting nicely and we make them wear the mask and we start the machine and we make them get used to the breathing with the machine, and then only we do the titration so that they are kind of comfortable. And even if they are not comfortable when they are awake in the afternoon, we give it. So Dr. Shyam, this was fantastic. I think this tip is what is important. The experience is something which is going to help all our listeners. We have, I think, 2,679 live logins, and this was at 9:11 p.m. I've not been able to check messages after that. So we have huge number of people who are listening to us, and thank you so much. This was like really a complete answer as to how to go about starting CPAP therapy. So now coming to Dr. Shivani. So Shivani, you did tell us in the talk also, but for the benefit of others who might have joined late, I just want to ask you that should PAP titration be done in all the OSA patients and why?
So, ma'am, ideally, PAP titration should be done for all patients because if we do not titrate, we are actually, hitting in the dark about what their pressure requirement is actually going to. So this is, I always tell my patients that why titration is important, and I give them a small example. It's like checking for refractory error because everybody has a different power. So similarly, your requirement for the PAP therapy is going to be different from other patients. So there is no one size fits all, and hence titration is important. But then we should also keep it in mind that there are going to be cases who would not only be okay with just CPAP, they might actually need a higher pressure, wherein we may need to switch them to a bi-level. And also there are times when patients actually develop treatment emergent central sleep apneas. So those are also patients wherein we have to be cautious because most cases would actually, recover on their own once on continuation of PAP therapy. But however, in few patients, we may actually need to upgrade their equipment to a bi-level with a timed breath or maybe sometimes even an ASV. So hence we have to be really cautious and go ahead and titrate all patients is my opinion.
Yeah, this was fantastic, and I could never agree more with anybody else. I just want everybody listening to us that CPAP titration is mandatory. We know of a lot of people, especially they're not pulmonologists, they are medicine intensivists, etc. What they do is they tell the patient take auto CPAP, use it for a week. We'll take out the average data and we'll give you those pressures. But that is not okay at all, because by doing this we end up over titrating and we end up giving them a higher pressure, and people who get a higher pressure are the people who end up getting treatment emergent central sleep apneas. And therefore, as Dr. Shivani rightly said, just refractory error. If you have an I number, you have to check what the number is needed. You just take out, can't take an average. So CPAP titration is mandatory, and everybody who wants to practice good sleep must definitely make sure that titration is done for their patients, and based on what is the pressure the patient requires, that patient is advised for the patient, which is called the effective pressure. Thank you so much, Shivani, for this great answer. Now coming to Dr. Chawla. Again, sir, congratulations for the fantastic talk. I found it extremely informative and also entertaining. So I want to ask you that how do you decide if to give fixed CPAP or auto CPAP? And what are the advantages and disadvantages of both? And what is the average cost of each?
Amita, again, I will add my experience to it since I am using and doing sleep. I introduced the sleep and Delhi. Home sleep studies I introduced. Right. I have around 6 sleep labs with me, 3, 4 of level 3, PDX2, LS5. I don't have LS6 because transcutaneous and all CO2 motor is all cumbersome. Adding what you are telling repeatedly, the CPAP titration, I am sure you mean manual CPAP titration, not the auto CPAP titration. Majority of the labs are doing auto CPAP titration. I was reading one question from Dr. Jackishan. He was putting it, it just came as a flash. The technicians are doing it. Yes, technicians are doing it. Those who are listening are holding sleep labs. ये तपस्या है. ये तपस्या है. अगर आपको sleep practice करनी है, first learn to be awake in the night. I remember when I came to the country in 1996, when I learned from Prince Alfred Hospital, Professor Colin Sullivan, believe it, the way the sleep clinic was run, the way the ResMed factory I visited, the way the CPAP was manufactured, it was called as Colin Sullivan CPAP. They were Sullivan CPAPs, right? So that was the time when you learned the manual CPAP titration. As the sleep business grew, the companies made a fun of this sleep. They are responsible what is happening in the country. They are giving you technicians, they are giving you sleep labs, they come, they do, they charge money and get out. And give you कि आप auto CPAP खरीद लो. सच्चाई यही है, लेकिन ये कड़वी बात है. Sleep is a tapasya. If you can do titration manually, if you see them, what is the quality, if you can give them the video recording of their sleep and what is happening to them during sleep is eye-opener to them. When you show them what has happened in the night, what is the quality of sleep, what are the apneas and hypoapneas happening, there is no question he will not accept a CPAP. You discuss CPAP before putting the patient in the PSG lab. Sleep to tapasya hai, lekin tapasya ka gimmick banaya hua in all companies. They want to sell CPAP at any cost. Coming to this question of fixed and auto, again, you need a mobile basic जो 500 रुपए का है आज भी. Hello, hi, क्या हाल है, कैसा है? Mobile is used for telephone. So if you have Apple 16 today with all extra features, telephone का काम तो 500 रुपए वाला telephone कर रहा है ना. CPAP भी वही काम कर रही है. The basic CPAP is doing what your AirSense 11 costing 81,000 is doing. You are adding features, you are adding Bluetooth, you are adding your luxury, but motor सब में same है. Motor की capacity सब में same है. The kind of a business they were doing is 25,000 की जो CPAP ResMed की थी, they increased the price to 35 because they were opening this new machine, taking out a new motor and putting and repairing the 81,000 machine or 75,000 machine or 65,000 machine. They increased the price because of that. 23,000 rupees machine does a wonderful job. Shivani said, if you do manual titration, I am sure fixed pressure CPAP scores over. There are various RCTs, there are meta-analysis. They have proved the fixed pressure CPAP and auto CPAP. They are more or less equal. But if you go by quality, sensitivity, beauty of the machine, the pressure tolerance, reducing the pressure with this, making your RAM, definitely auto CPAP is more comfortable because you are holding a 1.5 lakh rupees ka iMobile and having an 81,000 Air Sense 11, but your patient can afford 23,000 machine. I am very happy with that. So I think I have answered your fixed and auto and the price and discussion, and responsible are sleep companies. We physicians, respiratory sleep physicians are equally responsible for encouraging them. We know our vested interest. I don't want to open up. The whole sleep market has been destroyed by the Philips and the ResMed people. Let them listen if they are listening, Rakesh. Thank you.
Okay, sir. Thank you so much. You're always so honest, and it's very heartwarming to hear these honest comments. So I would just, because sir said many, many things, just to kind of wind up everything, we have fixed and automatic. So basically, if a titration is done and you're giving the correct pressure, then fixed and automatic both are equally good. The only thing is that if the pressure requirement is high, then my patient might just be a little more comfortable with auto CPAP. If the pressure requirement is more than 13.5, patient might be little more tolerant to automatic CPAP. And the other thing is that advantage of auto CPAP is that it changes from breath to breath. So it is little more easy to tolerate it. But having said that, if money is a problem, please give your patient fixed CPAP. It'll do exactly the same job. And also, we must know that every CPAP machine has a data card, whether it's fixed or automatic. So basically, once we start the CPAP for patients, we tell the patient to come after, say, about a month to us with the data card report. And there are two important points I want to make. The first one is that whenever a patient has sleep apnea, which is not treated, this is outside the questions. I'm talking something different. So the thing is that whenever a patient of sleep apnea is not on treatment, every time he chokes, the soft palate vibrates and there is edema. And therefore, when the initial CPAP titration is done, we overestimate the pressure. And when the patient starts using the CPAP regularly for 3 to 4 weeks, the edema goes away and the actual pressure comes down. And therefore, please make it a point to call your patient after 3 to 4 weeks with a data card, and you will realize that the percentile has changed, and then you might be able to reduce the pressure. So this data card is available with every machine, whether it's fixed or automatic. And therefore, based on the readings, you can keep on adjusting even pressures of the fixed as per the patient's requirement. And the cost and everything, Dr. Chawla has very nicely told us. Fixed is much cheaper. Fixed basically, if the patient is not affording, it is totally okay to give them fixed machine because it'll do the job. And of course, automatic is a little more comfortable, and therefore an affluent person might just want automatic, but it'll do the job. So thank you so much. And I just love to listen to your experiences. It just brings out so much of tadka to the discussion. Okay, now coming back to Dr. Tampi. What are the different types of masks which are currently available, and which type is preferred when, and what is your favorite?
Thank you, Dr. Amita. At the outset, I must say Dr. Shivani had covered quite a bit about the mask, and it was very informative. So I'll just re-emphasize most of the points. There are several types of masks used in continuous positive airway pressure therapy for obstructive sleep apnea. The choice of mask depends on individual preferences, facial structure, and specific needs. So if you look at the types of masks which are available, which Dr. Shivani had shown us very nicely, nasal mask, which cover the nose only, and it is suitable for patients who breathe through their nose during sleep. Then we have the full face mask, which covers both the nose and the mouth, and it is ideal for patients who breathe through their mouth or have nasal congestion. Then we have the nasal pillow mask. These are small cushions, which all of us know, that fit into the nostrils, and it is suitable for patients with facial hair or who prefer a more minimal mask. Particularly the large mask scares some of them. Some of them may have claustrophobic, feeling when they put on the mask. So they feel uncomfortable. Whereas the nasal pillow, gives them that freedom from being enclosed in a face mask, right? And then we have the hybrid mask, which combine features of both the nasal pillow and the full face mask, providing a seal around the nose and the mouth. And of course, the oral mask, lastly, which cover the mouth only and often used for patients who breathe through their mouth during sleep. So now about choosing the right mask. The best mask for a patient depends on several factors. Firstly, the sleeping position. Side sleepers may prefer nasal or nasal pillow mask, while back sleepers, people who sleep supine, may prefer full face mask. The facial structure. Patients with a beard or a mustache may prefer full face or hybrid mask for obvious reasons. Then the breathing patterns. Patients who breathe through their mouth during sleep may require full face or oral mask, as I mentioned earlier. The comfort and preference is important. Patients should try different masks to find the one that feels most comfortable and suits their needs. So that brings us to the question, what is the single best mask for all OSA patients? The most effective mask, I emphasize, is one that fits comfortably and provides a good seal without being too tight or too loose. It meets the individual needs, takes into account the sleeping position, the facial structure, and the breathing pattern, which I have explained. And most importantly, it should be used consistently. Patients are more likely to adhere to therapy if they find the mask comfortable and convenient.
Wonderful. That was a superb answer. And I would like Dr. Chawla to add.
Dr. Tampi, very modest, very soft spoken, no arrogance, nothing. I love you when you have visited Delhi. I really have a lot of regards for you, sir. Putting mask in practice, I ask my patients to spend money on the interface. That is closest to your face. Don't spend on the box, which is a magic box. Take a fixed pressure, buy 2 masks. Best mask when it comes to the bargaining, ask him to show all plethora of masks to you. Pick up the softest silicone mask, because any mask is going to put on the nasal bridge a spot. Change it to the nasal pillow. Use it. Nasal pillow is fantastic with the nasal mask. Interchange these 2 masks. Have the best of word with you. Spend 5,000 rupees for extra for this. Bargain on the machine, no problem. Buy fixed pressure, but buy best quality 2 masks, because that is what is closest to your face.
Very well said. So again, fantastic inputs by Dr. Chawla and a superb answer by Dr. Tampi. Basically, the thing is that patient has to be compliant and therefore mask has to be of his choice. It's all about contact lenses. Some people feel soft are good, some feel semi-soft are good. So whatever suits you, because so patient should be deciding. But I like one point about people who are side sleepers, they should go for nasal pillow because there is no air leak. Otherwise, with the other mask, there will be air leak, as rightly said by Dr. Tampi. And thank you, Dr. Chawla. I think this, I am not doing it. I have 2 masks, nasal pillow and the nasal one. I think this is so good. And we always tell our patients that try every mask and decide. And please do this, because what is good for me, what is comfortable for me may not be comfortable for the other person. So great. I'm just so happy that all our 5 faculty are sleep champions and they're giving us so much of information from their personal experience and vast knowledge. Now coming to our Dr. Nithya. So when do you consider BiPAP in OSA? Because we are only talking about CPAP. So please tell us, when do you consider BiPAP in OSA patients and how much does it cost?
So BiPAP, as has been said by Dr. Shivani, when we, in the manual titration algorithm itself, once we reach a pressure of more than 15 centimeter, it is better to go for the BiPAP titration, because if the pressure is going beyond 15 and still the events are still coming, it is better to go for BiPAP, because that would be more uncomfortable period for the patient. And ultimately, if you are asking the patient to keep your CPAP at a pressure of 17 or 18 or something, ultimately they won't be using it. So when the pressure goes up, it is better to go for BiPAP. And the other condition would be when there is a central hypoventilation disorder or something like that, then there would be a role for BiPAP. So those are the conditions in which definitely a BiPAP would be indicated. And obviously, the problem with giving a BiPAP is its cost. So whenever the BiPAP, the CPAP will come, a manual one will come around 30,000 or 40,000, and auto one would come around 50,000. When you're going for a BiPAP, the cost almost doubles. Like it would be starting from around 60, and it would be going to more than 1 lakh. So before you decide on giving a BiPAP of the for the patient, make sure that the patient is really needing a BiPAP.
Wonderful. Very well said. So basically the thing is that as Dr. Nithya said everything, I would also like to add that if patients have COPD and OSA, then we prefer to give BiPAP upfront. And about the cost, I just want to say this very forcefully because, we should know so that we can bargain, because these people who sell machines, they are actually business people. So the thing is that today you can actually get a CPAP for 27,000. If you bargain more, you can even get it for 25,000. You can actually get a BiPAP, auto CPAP, fixed CPAP for 25,000, auto CPAP for 50,000, and you can actually get a BiPAP for 75,000 today. And by bargaining, you might be able to come down to 70. So the thing is that if your patient is poor, then good to know these rates. So then it's best to give two numbers. So when two people are bargaining, the patient will get the best deal. So thank you, Dr. Nithya. This was very, very useful when to use BiPAP. I'd like to come to Shyam now. What are the complications of PAP therapy?
So, ma'am, most of the complications actually it boils down to the fit of the masks and the mask. So, if you see, you can rightly start from the nose itself. So, nasal dryness, mild epistaxis due to crusting and excessive dryness, dry mouth. If the mask is not fitting over here, it can leak and cause eye dryness also, or redness of eyes when they wake up in the morning. Claustrophobia. Some patients, because of tight fitting masks, or if they apply too much pressure and fit it very tightly, you can have some ulcer on the nasal bridge. And aerophagia, these patients tend to swallow, or the abdomen tends to bloat because of a lot of swallowing of the air. These are the usual common complications which you see. And then there are rare complications like, barotrauma, especially in ILD patients who have sleep apnea, and if they're given high pressures. Largely, these are the complications which I usually encounter. So, yeah, that's about it. And Dr. Chawla will tell us more.
Wonderful, Shyam. It was just complete.
Absolutely, you are correct, Shyam. You did a wonderful answer with the local, the interface. All problems are with the interface. But shower effect. Patient will get sudden bout of water on his nose or the face when he is using an humidifier. So he is going to tell you, sir, naak ke upar na pani aa jata, muh ke upar pani aa jata. So you know this is the water level. He has to take care of the water level, keep it mid or low, not to the level where it is marked in the humidifier. Your 3 marks are there. Keep it in the middle or little lower, so that the morning it all dries up. And your air humidifier should be all dry in the morning. Otherwise, if the water is left behind, you are going to have another medical problem, because you have to change the water every day and it should be all dry. So with the experienced patient knows how much water I should keep, and it dries up by the morning. So with the heated humidifier, that drying up also sterilizes your humidifying chamber. So you are avoiding those diseases, including the fungus or any kind of the diseases. Plus this typical effect of shower happens when patient comes. So I just added from my experience.
Wonderful, sir. Wonderful.
Excellent. That's an excellent tip, sir.
Excellent tip. Great. Shivani, yes?
Yeah. So, ma'am, beautiful point made by Chawla, sir. I'll just like to add that sometimes even keeping the PAP machine at a slightly lower level than the patient also helps with the shower.
Sorry, just say slightly lesser pressure.
Just keeping the equipment at a slightly lower level than the patient's level.
Okay. Yeah, that's a very, very practical point. So I'd just like to say something that, humidifier need not be added every time. So we live in Bombay and we are very, very humid. And therefore, we actually don't give humidifier to anybody. unless the patient complains or in the middle of the night they are removing the mask, which means that they are becoming dry. And you will be surprised that without giving humidifier, none of our patients actually complain of dryness. So I think for places which are humid, we can avoid humidifier because of the fear of any transmission of diseases to these patients. But I think fantastic answer by Dr. Shyam and excellent inputs by Dr. Chawla and Shivani. Thank you so much. I'm just loving this discussion. We actually have 194 questions already, and I don't know how we're going to manage, but let's just slowly try to take each of them. So, Shivani, now coming to you. What are complex sleep apneas? Why do they arise, and how will you manage these?
So complex sleep apnea is basically a central apnea or treatment emergent central sleep apnea, which are unmasked, as they say, or occur when on initiation of PAP therapy. So why it happens is largely unknown, but it is believed that this is because of an unstable respiratory drive on initiation of PAP therapy in these patients, because there are changes in the CO2 levels and changes in the respiratory reflexes, and that's what usually leads to the occurrence of these treatment emergent central sleep apneas or complex sleep apneas, as we call them. In terms of management, sometimes we just have to, like you had mentioned, ma'am, reduce the pressure slightly so that we are not over titrating, and then they may actually vanish on their own. Sometimes we just need to give the patient some time to get used to the PAP therapy, and when we look for the compliance report, there may not be any complex sleep apneas visible. However, after doing all of that intervention, if there are still complex sleep apneas which have persisted, which are leading to arousals and desaturations, then we may actually need to shift the patient to a bi-level device with a timed mode or sometimes an adaptive servo ventilation to take care of these complex sleep apneas.
Excellent. So just to put it very, very simply, patients of sleep apnea hypoventilate in the night, and therefore they are used to a higher PCO2. The respiratory centers used to higher PCO2, and therefore once you start giving them CPAP, then they are not going to go into apneas, and therefore the PCO2 becomes less. This PCO2 is actually normal, but their brain and their pulmonary stretch receptors are used to higher PCO2, and therefore they will not initiate the breath, and therefore this will turn into central sleep apnea. Very beautifully explained by Dr. Shivani. And therefore, you want to make sure you do titration so that you don't over titrate to begin with. Because if you're giving higher pressures from the beginning, then higher chances of more PCO to wash out, and therefore higher chances of complex sleep apnea. And the thing is that, so this was fantastic. The way manage, just continue the same thing, reduce the pressure. Usually over period, it becomes okay. Only in some people, we need to change over to time mode, a bi-level. Just we need to remember that people who've got heart failure or people who are on opiates, they have a higher chance of getting complex sleep apnea. So look for it. But a fantastic answer, Shivani. Thank you so much. Very concise and crisp. Now coming to Dr. Chawla. Sir, how would you approach a patient who's still symptomatic despite PAP therapy?
See, when you have done a manual titration and patient comes and says he has got still OSA symptoms, you have to check adherence and effectiveness. Very important part. Ask him to bring the data card. All pulmonologists practicing sleep should have a software of ResMed, of Respironics, of the Chinese-made companies to download the data. Ask him to give you the card and you see the data, whether he is using it effectively or no. That's very important. Then you have the answer to the question. Mask fitting, leaks, comfort. Then you review the CPAP settings, whether it was done automatic or it has been done manual. If it is done an auto CPAP titration, please admit and do the manual CPAP titration and give him the right pressure to be all right. If still the problem is there, you investigate other causes like of excessive daytime sleepiness. That patient has a poor sleep hygiene. You can ask him to do the meditations, insomnia, morning headaches, dry mouth or nose, or patient gets fatigue. You can consider the comorbid sleep disorders like Shivani said, complex sleep apnea, central sleep apnea, which are not treatable with your CPAP. Upper airway resistance syndrome, you may miss out. Obesity, hypoventilation, or nocturnal hypoxemia from other lung diseases associated with sleep apnea. You have to make the CPAP very comfortable. If still these things are not being sorted out and you are not a pulmonologist, please refer it to pulmonologist. You must know to draw the line. उसी को भेज दो जो ये काम करता है to sort out the issue rather than becoming a technician dependent doctor of sleep in India. Majority of physicians are technician dependent doctors of sleep knowing nothing about sleep. If any one of this is listening, he will be amazed to know that they do not know anything about sleep. Thank you.
Wonderful. This was a fantastic answer. And I'm very, very happy that Dr. Chawla told us that it's important to check the compliance of the patient. And it's very, very easy because with the data card, you know how much he's actually taking. So this was very, very important. Just to add one thing that, sometimes patients might be really compliant. However, despite that, sometimes they may have drowsiness, despite their sleep apnea being covered, etc. So if they are being really compliant with the CPAP, and if you've ruled out everything like rightly said by Dr. Chawla, each and every point so beautifully enumerated by him, if the drowsiness is still persisting, then in some people you may need to give over and above modafinil during the daytime to take care of the drowsiness. Otherwise, I also liked what you said about the leaks, because leak is very, very important. We often don't really think about. So thank you, Dr. Chawla, for this fabulous answer from your great experience in sleep medicine. Now coming to Dr. Tampi, when to repeat a PSG in a patient who's already on PAP therapy and why?
Yeah, it's a good question. For patients with obstructive sleep apnea who are already on positive airway pressure, repeating the polysomnography may be required in some of the situations. For example, as Dr. Chawla had just mentioned, the titration, if it's not done manually and it has been done in an auto CPAP kind of auto CPAP titration is done, then it may not be accurate. And the optimal PAP settings we need to re-establish by doing a repeat polysomnography to refine the treatment plan, right? The other indication is treatment failure. If a patient is not responding to PAP therapy, a repeat polysomnography can help identify the cause of treatment failure, such as inadequate pressure setting or mask issues. Then the change in symptoms. If a patient's symptoms persist or worsen despite PAP therapy, a repeat polysomnography can help assess the effectiveness of treatment and identify potential issues. Then, after using positive airway pressure therapy, there may be weight changing. Significant weight gain or loss in a patient can affect OSA severity, and a repeat polysomnography may be necessary to reassess the patient's condition and adjust the treatment settings. Then, lastly, the surgical interventions. After surgical intervention for OSA, such as UPP as was referred to recently, repeat polysomnography may be necessary to assess the effectiveness of the procedure. So why do we repeat polysomnography? To optimize the treatment, to identify issues and improve outcomes. By repeating polysomnography in specific situations, we provide and ensure that patients with OSA receive the most effective treatment and achieve optimal outcomes.
So this was fantastic. Superb answer. I just want to add 2-3 things. After using proper CPAP therapy, if the patient is still drowsy, then it would be good to get a PSG done on the patient to see if while the patient is wearing the machine, do a PSG to make sure that this patient is not getting complex sleep apneas or treatment emergent sleep apneas. And these would be diagnosed by doing a PSG while the patient is using the CPAP. That's number one. In addition, I would also like to add that very often sleep disorders coexist, and many patients of obstructive sleep apnea can also have periodic movement syndrome in the night. Now, the thing is, to diagnose PLMS, you're actually first supposed to eliminate OSA. You're supposed to treat OSA with the CPAP, and the patient has to be using CPAP for at least 4 weeks. And after that, also, if they complain that my legs are paining in the morning, etc., then you can actually do a sleep study to rule out a coexisting PLMS, which was in addition to a treated OSA. And third is to rule out narcolepsy, because again, a patient of OSA could also have narcolepsy separately. And again, for narcolepsy diagnosis, we have to treat the sleep apnea. So if we are suspecting narcolepsy, patient has still the MSLT is reduced despite using the CPAP, which the patient is compliant with. So to rule out another coexisting sleep disorder, after the patient, treating the patient for at least 4 weeks with CPAP, you may need to do a PSG while wearing CPAP to make sure that a coexisting disorder is not missed out. And in addition, Dr. Tampi told us everything else in a very fantastic way. Thank you, Dr. Tampi. Shivani, did you raise your hand?
Yes. Your list, also COMISA, I think, is a majorly recognized disorder today.
Yes. Yeah. Correct. Superb. So this was great. I just feel that this is such a great webinar because I'm picking up so many points from the panelists, which I did not have in my mind when I made the questions. So y'all are actually educating me, and I'm so grateful to y'all for educating me genuinely. Okay, great. So now, after Dr. Dampi, I would like to come back to Dr. Nithya. So, Dr. Nithya, coming to you, what is the role of position therapy in OSA? Dr. Chawla very well told us, but we want to know from you, what is the role of position therapy in OSA? In which patients would you suggest it, and how will you ensure it?
Well, actually, Chawla sir has elaborated a lot on positional therapy, so there's not much for me to add on it. But then also, I'll say so. This positional therapy, it works for specific group of patient who is having a positional OSA. That is, whether when the patient is having the symptoms more in supine position compared to the other lateral positions. So it is necessary to have a proper sleep study to diagnose this positional OSA, and we must make sure that this patient should be benefiting from this positional therapy. And when you come to the positional therapy, the simplest one would be that 10 rupee method that the Chawla sir told, just stitching it in his ball. But now the advances like the vibrating devices and those kind of things can also help. Another thing, if the patient is so much reluctant, then it is like, I want to sleep in the supine position itself. Another kind of position therapy is to give a wedge pillow. That is, if you're giving a 7.5-degree elevation, that would also help in improving the sleep. So whether he can sleep supine or lateral or anything, he just have to sleep in the this with this wedge pillow, and that will also improve the sleep. But all these things, these would work only in that mild to moderate OSA group. So if you're going for the severe OSA group, this is not something which you can give it as a standalone therapy. So if in the mild OSA the patient is reluctant to use mild and moderate OSA, the patient is reluctant to use CPAP, yes, you can go for the positional therapy, but you have to periodically reassess the patient, look his the sleep quality questionnaires and other things to see if your therapy is working.
Wonderful, wonderfully said, Dr. Nithya. Thank you so much. And what I really liked about your what you said was that only patients with mild OSA you want to give position therapy or moderate, but not for severe. So this is very good. And position therapy, especially for people who have apneas or hypopneas, only in a particular position. If they are having apnea, hypopneas in every position, then position therapy would not help. But these people who might be choking only, say, in supine position or one lateral position, in them, position therapy would be great if they are not ready to take CPAP. Superb. Thank you so much, Dr. Nithya. I'd like to now come to Shyam. So, Dr. Shyam, please tell us about the types of oral appliances currently available. When will you advise them? And what is their role in management of OSA?
So, oral appliances, basically, they've been approved for, as second line therapies where, CPAP patients are not tolerating the CPAP or they refuse to use CPAP in general. You have mandibular assist devices. Dr. Chawla had very nicely shown us the different options along with the videos. So in patients with retrognathia, especially when the jaw is slightly back, there's a very narrow space in the retropharyngeal area. You can advance the mandible to an extent so that the space is widened and the airflow is and the obstruction is relieved. So those surgeries are there. You have tongue retaining devices where the tongue the muscles of the tongue, they are stimulated, or the devices which prevent the tongue from falling back or helps in protruding it in front. You have soft palate lifters, which stimulates the with the pillars, the posterior pillars and the soft palate where the obstruction is relieved and the area is made slightly larger for the to relieve the obstruction. You have tongue stimulation devices, where you have devices which can stimulate the genioglossus muscle and that can help the tongue protrude. So these are the different devices. It's not, I haven't personally used the mandible assist devices. Couple of patients have, a very few people actually do these therapies, and it has to be really very well done to get the real benefit of these devices. So let's see, as PAP therapies improve, probably these would take a backseat. It's only for patients who refuse PAP therapy, these devices are recommended.
Wonderful. I mean, Shyam, so well said. I would just like to say that at least in Bombay, I don't know about the other parts of the country, but for all my colleagues living in Bombay, I would like to let you all know that now we have actually a dental specialty. There are dentists who actually specialize in sleep apnea treatment of making devices. And actually, I have been referring a lot of patients, younger patients. Like, for example, we have young women who are not married and they have obstructive sleep apnea, especially because they have retrognathia, which is very commonly seen in India. We Indians have a very high chance of retrognathia. So the thing is that these girls are kind of happier wearing a jaw pulling device all through the night than wear a CPAP, because of course it would be a problem that you're not even married and you're wearing a CPAP. So of course, again, just to say that CPAP therapy is the best, but we ought to know about everything that is available, because very often patient may not be happy to wear it all through their life. So, but again, it's only for mild to moderate sleep apnea. If it's severe sleep apnea, then please go always for PAP. And thank you, Dr. Shyam, for informing us about all the different devices and the way they work. Thank you so much. Now I'd like to come again to Dr. Shivani. So Shivani, what is DICE and what is the role of DICE before considering surgery in OSA?
So thank you again for the question, ma'am. So DICE is actually drug-induced sleep endoscopy. This is a procedure which usually our ENT colleagues are doing for us. So at least, however, even when we do sedate a patient for bronchoscopy, and sometimes even as pulmonologist, we notice the airway collapse as well. So what DICE basically does is it is evaluation under sedation for the levels and the extent of airway obstruction, whether it is partial or complete, and also the levels. So it is, since it is drug induced, the drugs that we commonly use are propofol, ketamine, midazolam, and dexmetadine. So these are usually the commonly used drugs. It is recommended to be done with the anesthetist and not independently. And once the patient has been sedated, they do a nasal endoscopy and look for the level of obstruction. Now, the level of obstruction that they look at is usually at the velum, the oropharynx, the tongue, and then the epiglottis. So, depending upon the level and the extent of the obstruction, they decide what surgery might actually help the patient. And very often, if the level of obstruction is actually circumferential, then those patients are actually not good candidates for surgery. So even though DICE was actually formulated to ascertain what kind of surgery the patient might actually be helped by undergoing, however, it has not been absolutely flawless. There are certain flaws to it. And I think since I read one question about when to advise UPPP, so if the collapse is at the anterior-posterior palatal level, then those are patients who would actually benefit from UPPP. So that's where the role of DICE comes. When I advise DICE to my patients is when usually they have moderate to severe sleep apnea, but are not benefited or not tolerating PAP therapy. That is when I do usually advise them to undergo a DICE.
Wonderful, wonderful. Yes, Dr. Chawla.
Amita, we are not experienced to have the specific level of obstruction. You are doing day in and day out, you are using fentanyl, midazolam, you are giving a sedation. There are patients who fight and you use propofol. Even in your bronchoscopy suite by calling an anesthetist, you see it from nose to the hypopharynx, up to the vocal cords and down into the glottic area, or doing an oral, seeing the soft palate, uvula, epiglottis, posterior wall, and this. Now the beauty will be that you submit this video to the artificial intelligence. Here where the pulmonologist will be smart of knowing which level the surgery should be done, and whether UPP, because I told you, the ENT people are doing majority is the uvulopalatopharyngoplasty. The problem is
A similar question to you now. If you
surgeon is very experienced, because if that fails, this is where the dice is important. So we are responsible for not harming the patient. You don't do, no problem. If your action has harmed the patient by virtue of over enthusiasm, that is going to create a hell for the life of the patient.
Absolutely. So the thing is that always a patient has moderate to severe sleep apnea, always go for CPAP, PAP therapy. But for some reason, if patient is reluctant or can't tolerate, and if you're planning surgery, then according to me, a DICE is a must. So that some patient might have obstructions at more than one level. So it should not be that only one level is met with. And fantastically said. Great. Now, sir, I'm coming back to you. You have said this already fabulously in your talk. So just a little bit in short, if you can help us telling, when would you advise surgery for OSA? Which are the surgeries that would help, and what is their role in management of OSA?
See, the goals of the surgery are to widen or stabilize the upper airway. You reduce the airway collapsibility. You improve the airflow during sleep. You reduce apnea-hypoapnea index so that the patient quality of life is improved. The patients who are CPAP intolerant, non-adherent, anatomical problems, mild or moderate to severe sleep apnea, BMI is more than 35, are the candidates. And what are the evaluation tools for the surgery? As has been narrated by Shivani, DICE is very, very important. Then you have a cephalometry or imaging. They do MRI, CT, merge the images, they measure the airway collapse, which is the area which is the narrowest. They combine DICE findings with the cephalometry and find out the area of obstruction. Then polysomnography to grade the severity is an asset when you are submitting the patient for surgery. As you say, the type of surgeries I have enumerated: UPP, tonsils, adenoids, genioglossus advancements, maxillomandibular advancements, hypoglossal nerve stimulation. These are, and HNS is taking the things as a storm now. And to add to Shyam, over the counter in USA, FDA approved tongue retainers and mandibular advancement devices, as Amita said, for the girls. They are over the counter product. I do not know, India, the companies are not getting much benefit to bring them here to sell. Otherwise, there should not be any reason. And advantage our patient may get the permanent long-term relief. But issues are that not universally effective. Surgical risks are there of the bleeding, infection, and I said, if the UPP fails and you are the referring physician to the ENT specialist, you have to face the music. And CPAP again will not be effective. So you need to have a very thought-provoking ideas for the invasive surgeries when you are going to offer to the patient.
Wonderful, sir. This was fabulous. I just want to tell all the audience that I'm just getting so nervous because we have 277 questions. And I don't know, even if we are talking till 3 days more, we will never finish them. So we are trying to take as many questions as we think will help management. And I apologize already if I can't take more.
You have broken the record of the audience or no? Amita has broken.
Yes, sir. I think I'm just checking. I'm just going up and down, sir. 1 minute. We have 2,681 doctors live right now. 2681.
So we have broken.
We have broken. I mean, come on, with faculty like you all, we had to, So no prizes for guessing this. And hats off to our faculty again. Coming to Dr. Tampi. So what is the role of, we pulmonologists love oxygen. So what is the role of nocturnal oxygen in patients of OSA? What are the advantages and disadvantages? And when would you advise it?
Yeah, quite true. We all wonder when to use oxygen and when not to use. But there is a role of nocturnal oxygen in these OSA patients who are on PAP therapy, right? So supplemental oxygen can be given, which helps to increase the oxygen levels in the blood, particularly in patients with OSA who experience significant oxygen desaturation during apneic spells. So these patients could be given, when they experience this kind of extreme desaturation, we could allow them to take nocturnal oxygen. Then, in the presence of comorbid conditions, such as patients with OSA with underlying conditions like chronic obstructive pulmonary disease, heart failure, or pulmonary hypertension, this may benefit from nocturnal oxygen therapy. What are the advantages? The advantages are improved oxygen, naturally to help maintain the adequate oxygen levels and reducing the risk of hypoxemia-related complications. The second most important advantage is the reduced strain on the heart by increasing the oxygen levels. Nocturnal oxygen therapy may reduce the strain on the heart, potentially benefiting patients with cardiovascular comorbidities. What are the disadvantages? There's increased complexity because you're adding one more oxygen supply, which needs to be monitored and adjustments to be made. There is also the most important disadvantage is the potential for CO2 retention. Supplemental oxygen can lead to CO2 retention in some patients, particularly those with COPD or other respiratory conditions. So when to advise nocturnal oxygen therapy in these patients? When there is significant oxygen desaturation, underlying respiratory conditions, cardiovascular comorbidities, which I have highlighted. And it can be valuable adjunct to CPAP therapy in OSA patients with specific conditions.
Wonderful. I think this was very, very well said. We just want to be sure that we don't retain carbon dioxide. And also just by giving oxygen alone, though the patient will not desaturate, it will prolong the apnea as in sympathetic overactivity. So try to give CPAP when it is due. And in addition to CPAP, you can give oxygen. There's no problem. So great, Dr. Tampi. That was great. Now, coming to Dr. Nithya, what is the role of nasal EPAP in OSA management? Dr. Chawla already told us, but it's a new thing. So if you can tell us in detail about it, in short about it.
Yeah, this nasal CPAP is something new in the field. And actually, there are there are a few studies regarding this. So what here, we know for obvious reasons that the CPAP, though we say that it's the gold standard, when you come to the adherence of CPAP, there are pretty big issues with the adherence. So even if you give CPAP to some 100 patients, there would be hardly 20 to 30 patients who are totally adherent to that. And the rest of the patients, you do have some issues with adherence, there we'll have to go for other techniques and all. And this would be another thing which would be introducing a expiratory caustic air pressure. So what we are doing is it's a valve kind of thing. It's a one-way valve which is placed inside the nose. So it will allow for inspiration, but during expiration it would be a partial. So as a result of that, there will be back pressure which is created, and that would create a kind of a peep. And this will prevent the collapse of the airways. And there were some studies which shows adherence almost same as the CPAP adherence.
This was a wonderful answer. I mean, thank you so much, Dr. Nithya. And I want audience to know about this. This is basically Provent. It is actually available. And people who can't use CPAP, I think this would be fantastic. I have used it for 3 of my patients. In fact, the person who made it, he is from Los Angeles. And I have met him. He's an Indian, he's in Gujarati. And he actually had left a few samples with me for his patients. And the results were fantastic. Patients were very happy. It was only used for people who were not happy or compliant using CPAP. So please consider using this. It's called Provent. And even the technology is wonderful. It makes sense. And hats off to people who thought about this. So Shyam, coming to you. So, Dr. Chawla spoke about hypoglossal nerve stimulation. So can you please tell us about what it is and its role in sleep apnea?
So hypoglossal nerve stimulation is another one of the devices which are approved for patients who are intolerant to CPAP. It's not like the first line of therapy. It basically is a device which is more like a pacemaker. It's placed just below the clavicle, right, below the inferior part of the clavicle, and then there's a wire which goes and near the mandible where the hypoglossal nerve is there, it goes and stimulates that nerve. And there is one lead which is somewhere in the lateral chest wall which detects inspiration and expiration. So at the start of inspiration, when the obstruction is the maximum, the sensor detects that and it sends an impulse through the wire, and it stimulates the hypoglossal nerve, which in turn, stimulates the genioglossus muscle and the hyoglossus muscle to stiffen and protrude the tongue. So once that happens, when the tongue is stiffened and it protrudes in front, the cross-sectional area of the oropharynx increases, and that prevents obstructive symptoms. So that's the basic science behind this, and there's only one company, I guess, which makes it, called the Inspire. I don't know if it's available in India or not, but this is how it works.
Wonderful. Okay. Now, actually there are still, okay, Shivani. Yes.
So, ma'am, wonderfully explained by Dr. Shyam. So it's not yet available in India. And of course, the cost is huge if people want to go overseas and get it. I think it's around $50,000 plus the surgical charges. But also there is another new equipment, which is a bilateral neurostimulator, which is called Genio. Again, that's also not available in India, and it's under studies in the US yet.
Great, wonderful. So, I'm just quickly going to, I think let's just, first of all, there's a big request from all the kinds of audience. Everybody is saying that don't stop the webinar. We actually, 10:38, they are saying that please continue and answer all our questions. There are 277 questions. I'll try to do as much as I can. So just requesting all our faculty to give try to give 1 to 2 line answers, Okay, this is, Shivani, it's a very interesting question. So Dr. Vishwesh is asking from Bombay. And I had also kept this question, so I just took his name. So newer drugs, GLP-1 analogs that are approved for weight loss, what is their role in OSA?
So, ma'am, there are 3 GLP-1 analogs which are actually approved in OSA. The most common one, which is, for weight loss, but also there's only one which is approved for OSA is tirzepatide, which has just come into the Indian market. In the Indian market, it's still not approved for OSA management, but only for weight loss, actually. And of course, the initial studies showed that there was a lot of improvement in sleep apnea, also to the tune of 42 to 57%. However, there is just a paper which was published on the 10th of June, which said that there is no, in the real world, there is not as much weight loss. So I am not certain how much it helps. However, there is also a drug which has just passed the level 3 trial, which is, I think, called AX109, which claims to also be the first pharmacological treatment for just OSA. So I think that's where we are in pharmacological therapy in OSA.
Yeah, wonderful. I'd just like to add one thing that, we all know patients need to lose weight. So these weight reducing medicines are fantastic. But in addition, tirzepatide has also shown to affect the sleep. So it basically it improves the quality of sleep and it reduces the arousals. So over and above, it also actually has effect on sleep apnea. So that is something which is very, very promising. The mechanism is not known, but it would be good to use these medicines. And in Bombay, we are just using so much of it. Dr. Chawla, I would like to ask you this question, which is asked by many of our audience: how to improve compliance of CPAP?
Again, a mixture of the answer of the previous, already elaborated by the all panelists. First important thing is you should be honest. मैंने आपको बताया तपस्या है manual titration. That's very important. Show the video, educate the patient. Show them the video of their actual sleep study. Educate the patient how CPAP is used, because patient will ask you, sir, क्या treatment होगा इसका? आपको heart of heart पता है इसको CPAP की जरूरत है. आप PhD और sleep करने के लिए CPAP को discuss नहीं करते. There are reasons, there are truths. You discuss CPAP first. Show the videos how CPAP looks like, how the interface looks like. Your compliance level is going to increase if you educate the patient and talk truth. Personalize, as we have already discussed, the interface, the mask fitting. The best possible mask patient should get and should be very comfortable. Then you have to, if the patient is anxious, claustrophobic, insomniac, you can always take a sleep psychologist. There's a new terminology which is coming, is a sleep psychologist who will be walking in and helping counseling the patient. You can help the patient to track him through the data. As you said, every CPAP machine has got a data card. You can use mobile apps. The latest machines have got the mobile apps. You can track the progress. You can boost there and encourage them to be more regular for all this. So education and the family support is very, very important. You have to educate the family, motivation, psychology. Then the patients have got an aerophagia. So air swelling, you must address that issue by reducing the pressure for some time. Here where you need an auto CPAP, it will definitely help you to reduce aerophagy. So auto CPAP has got very specific indications, which are 10 or 15%. So you must have a contact period with the patient. You have done the job, you have given a CPAP, you must keep a contact with him. Just call him 1 or 2 weeks to see that patient is using it. हाल चाल पूछना है, whiskey छोड़ दिया कि नहीं छोड़ दिया है, smoking छोड़ दिया कि नहीं छोड़ दिया. You try to be intimate with the patient, and I'm sure, and ask him monthly for follow-up in the beginning. And you involve the bed partner, because that is the most important. You ask, you talk, she will say engine shuru ho jata. That's the terminology they use. Bachche has become chartered accountant by virtue of parents being snorer and sleep apnea. कहता मम्मी पापा का इंजन चलता रहता था, मुझे नींद नहीं आती थी, मैं पढ़ के चार्टर्ड अकाउंटेंट बन गया. The wife says कि husband का इंजन चलता रहता है, mask को ठीक कर देती है. So the moment she corrects the mask, engine stops. So she plays a very important role for compliance. Her positive support to the partner is very, very important to increase. As I said, behavior and the psychological supports are important. As you said, gradual adaptation, desensitization. You are doing it in the noon that patient gets adapted to the CPAP before you go for titration. So adaptation, desensitization, optimizing the pressure sending. Then as Shyam has said, manage the side effects accordingly. So when you listen, do the interview with this, give some time. As I told you, we physicians have no time. Sleep is a tapasya. If you will talk, your compliance rate will increase. Otherwise, 1996 mein, it was 25 to 30%. Price was 30,000. Mockery is 2025. Price is 25,000. And the acceptability is maximum increase to 5 to 10% to 35%. Why? Can you explain? These people can explain why acceptability has not gone, price has not reduced, price has not jumped up. 30,000, 30,000. So you can understand everything. What is the actual price of CPAP? 5,000. Can you believe that? 5,000 is the price of CPAP. Thank you.
So, sir, I mean, just to conclude what you basically said, very, very important points made by Dr. Chawla. So the thing is that if you want the compliance to be good, you must do a titration. You must have an interface which is really comfortable for the patient. If the patient complains of dryness of throat, please add a humidifier. You have to make sure that there is no leak. You have to make sure that you check the data card and you make sure you keep on doing the pressure adjustments. You keep on checking how much machine patient is actually taking. Make the spouse of the patient or co-doctor with you who keeps on all the time insisting that the patient keeps on wearing the machine. And like inhalers, every time the patient comes to us, we have to keep on encouraging them, appreciating them, and explaining again and again how important CPAP is for them, because it's not about wear CPAP and go home. We have to make sure they continue wearing a CPAP, because how many of us will want to sleep with something on our nose? Yes, sir.
I just add, CPAP, believe it, all people who are listening, is not more than a negative vacuum cleaner. Price of vacuum cleaner, you know it. It will blow, it will suck. CPAP will blow with the chip involved, motor involved. So you can imagine how much is required, the price of the CPAP.
Yes, absolutely. So now quickly just taking questions. I think I'll just go in order. So coming to Dr. Tampi. Dr. Tampi, there's a very interesting question from Dr. Sayantan Samantha from Kolkata. When should upper airway stimulation like Inspire therapy be considered? The hypoglossal nerve, when should it be considered?
Yeah, I think this has been discussed quite extensively the hypoglossal stimulation by Dr. Shyam and Dr. Chawla as well. And I think we go to this level only when there is no acceptability for the PAP therapy, positive airway pressure. The patient is not able to settle with all our efforts. And then you want to go for non-surgical therapies. If the patient is not willing for surgical options, then one could try these hypoglossal nerve stimulation, etc. But again, this has been pointed out by Dr. Shivani. These devices are very expensive. Then the surgery itself, and then they are not available as yet in India.
Great.
So I think we should just hold on to these things and go for the conventional at the moment.
Okay. Dr. Ajit Kulkarni, a very good friend from Pune, from Kolhapur, he is saying, how do you approach treatment in patients with central sleep apnea components? So actually, we are going to cover this up in our next webinar. So Dr. Ajit, we will not answer it this time. We want you to join in next time also. Dr. Kritarth from Mohali, he's asking, how does management differ in pediatric versus adult OSA? Dr. Kritarth, we have a different module on pediatric OSA. So we will not answer this. You please attend that one. I would like to come to Dr. Nithya now. Dr. Pranavi from Mumbai, Maharashtra, she's asking, how do you choose which non-PAP device to be recommended and which is preferable? Just answer in 1 or 2 lines, please.
This has been said. This non-PAP therapies, when you go it on first hand, we go for this mild to moderate OSA cases only. But if it's severe cases, when the patient is not willing to use CPAP or not tolerant to CPAP only, we go for the non-PAP therapies.
Okay, great. I would like to say that Dr. Dhananjay Kamath actually asked the question again, how to improve long-term compliance of CPAP. Dr. Rakesh Chawla has wonderfully replied. I'm very happy and proud to tell you all that we have ENT also who have joined the webinar. So Dr. Supriya, ENT from Panvel, she's asking which cases would we suggest DICE. So Shyam, would you like to answer?
So I feel if there's a clear cut, DICE is basically done to define the level of obstruction. So if we feel patient is not tolerating the PAP, despite counseling, trying. I recently had a case where where the epiglottis was falling back with positive pressure. He had a small cyst there, and the epiglottis was very floppy, and it used to fall back. And the moment he used to wear the CPAP, it used to actually worsen his symptoms. So I feel these to define the level of the obstruction, that's where it helps very much. And plus, you have cases where the patient is not tolerant to PAP despite his or her willingness to use the machine. Then I feel you should definitely do it to see if there's anything wrong in the upper airways.
Great, fine. So very well said. So the patient is not tolerating CPAP. You need to subject them to surgery. Then we would like to do a DICE before advising surgery. Great, Dr. Shyam. Shivani, coming to you. First of all, Dr. Seema has said, wonderful talk by Dr. Shivani. My favorite topic. That is what she said. Congratulations, Shivani. I agree with her. And Dr. Snehalata Verma from UP is asking, what are the exercises which relieve OSA?
So I wonder if she's talking about myofunctional therapy. So there are a number of exercises which we can ask the patient to do. So number one that I ask them usually to do is hold a thread by their lips and try and pull the thread at the same time, and then keep holding on to it. So that is one. I ask them to also hold their tongue onto the palate while their mouth is closed, and hold it in that position and count till 10. So that's the other one. And similarly, like the thread, I also ask them to hold a spoon with their. So those are the ones that I usually advise them to do. And it's sometimes extremely helpful in patients with mild sleep apnea. So because it improves their muscle tone and sometimes may actually improve their AHI further.
Wonderful. So Dr. Sayantan also asked the same question, and thank you, Shivani, for answering it. Coming to Dr. Chawla. So Dr. Chawla, Dr. Dinesh J from Bangalore has said that your talk and your videos were very, very helpful. Thank you very much. And I'd like to ask you this question that what is your approach when patients complain of claustrophobia with CPAP machines, with CPAP masks?
See, as Shivani has shown the interface, different masks, nasal pillow, oronasal. So you have different varieties if there is a claustrophobia with the interface. Machine, I'm sure there should not be any claustrophobia. And you can always add on anxiolytic. You can always counsel. As I said, the sleep psychologists are now available to counsel and convince that claustrophobia from the interface should not be there when you have variety of options to use. And if he is able to tolerate CPAP, I am sure as per today, that is the best option.
Great. So thank you so much. I would like to take this compliment. Dr. Ajit Maror from Pune is saying thank you very much, Dr. Amita ma'am and ICS for giving us an opportunity to learn for this brilliant and hugely populous academic activity. So this is very, very good to hear. Hitesh just messaged me that we still have 2,600 people logged in, but I think it's 10:52. I'm asking faculty, should we just do one round of questions or should we stop it? Faculty is tired or into?
You decide and we stop.
Okay. So we still have, I think, should we just stop on a good note? This one question which is asked by 5 to 6 pulmonologists, they want to, I'll just ask about everybody one thing. Dr. Tampi, one very important question asked by so many of our own friends from Maharashtra is, what is the role of melatonin in sleep apnea? So would you...
Sorry,
melatonin.
Yeah, melatonin, of course, is a drug that is a hormone which is used for putting people to sleep. So I don't think that typically we use it in sleep apnea patients. I don't think we need to use it in OSA patients, at least. And these are, melatonin is a drug, or Melocet, or whatever it is available in 3 milligrams, 6 milligrams, etc., and 10 milligrams. It should be used only if there is difficulty in going to sleep. It's not an obstructive sleep apnea drug that we use. However, many of the OSA patients, on the contrary, have, need to be, they're too sleepy. So I think we need to use drugs like modafinil, etc., during the daytime to prevent excessive daytime sleepiness.
Yes, I agree. But the thing is that if patients have sleep apnea, if they are using the CPAP and they are still complaining of disturbed sleep, then melatonin would be very, very good. So it could be used. There's no problem. People are asking which dose. So 3 mg is something that we would be happy to give. But you can, of course, go up to 6 mg and 9 mg also. I'm just taking drug-related questions now. So I'll ask Dr. Nithya. Another question that is asked is, what is the role of what is the role of zolpidem in sleep apnea patients?
I would have the same answer as Sarah told, because mostly if it is sleep apnea, it is the excess sleepiness that it is a problem. But there are certain phenotypes of female OSA who do complain that they have a problem in initiating sleep. So they might have some amount of insomnia, and there might be sleep maintenance issues for some group of patients. So in those group of patients, maybe this kind of hypnotics might work.
Okay, so I'd like to just add that zolpidem is basically a safe sleep medicine. And if patients have COPD, for example, if they have to be given a sedative, then zolpidem is something which is recommended to be safe. And otherwise, if a patient of sleep apnea who's using the CPAP or even not using the CPAP, if we need to give them a sedative, then zolpidem is a drug of choice, including on the night of the first sleep study, diagnostic sleep study. If they don't get sleep, we give zolpidem because it doesn't affect their AHI. So I would say this would be the safest to give. There is a very important question.
Zolpidem plus Melcet is a combination which is available.
Which is available, exactly. I haven't actually used it. I haven't used the combination.
But you can use it for claustrophobia. You can use it to increase the acceptability of CPAP because it helps you to get into sleep, the sleep latency, which is again when you are using the RAM and you give zolpidem and Melcet combination, it helps you a lot.
Absolutely, very right. So coming to now Dr. Shyam. So Shyam, first of all, you have a birthday wish. Dr. Lava from Karnataka, Mysore. She's wishing you happy birthday, Shyam sir. So
Thank you.
yes, Shyam,
Thank
you're
you.
very popular. And basically, I'll just take 2-3 questions quickly together for you. Dr. Vipul Ghosh from Havra is requesting you to share a case of OSA with systemic comorbidities like hypertension, arrhythmias, who improved with CPAP. Would you like to share a case?
Yeah. So there, I mean, so in inpatient, there are a lot of cases where patient gets admitted with heart rate with a heart failure and concomitant AF or arrhythmias, and then there would be the typical patients. It would be you'll have a male or female with morbid obesity with some kind of airways disease. That's why they show us. And probably the COPD exacerbation or something which would trigger the failure or the arrhythmias, and then they get diagnosed. So once you see them, and you decide that you need to evaluate them for sleep apnea, because you can see the sisters will tell you, when they sleep, the saturation tends to go down. That's one clue you get in hospital during the inpatient phases. And then once, just prior to discharge, these are the cohort of patients whom we usually do a sleep study, or at least in the first follow-up, we advise them a sleep study. And then you see that once you start giving giving this the PAP therapy, a lot of the symptoms, the cardiac comorbidities, it's all under control after that.
Great. Wonderful.
It's very important to sensitize the cardiologist about sleep apnea and the treatment of sleep apnea, polysomnography. I am sure cardiologists across the country are not sensitized to take this as a sensitive specialty.
Fantastic cardiologists, and I would say even nephrologists. Any patients who have creatinine of more than 3, please sensitize them. If we are because they are the ones who have patients with all kinds of sleep apnea. Last 2 questions I'll take. We have just so many compliments, dear faculty. There are just so many compliments from so many of our colleagues across India, complimenting each of you on your fantastic answers. Shivani, there's a very interesting question from Dr. Jaikishan. Actually, it was covered last year, but he's our friend. He's posted so many questions. Dr. Jaikishan from Haryana, he's asking that would the OSA severity differ if you do a full night sleep study diagnostic versus a split night study?
Yeah. So excellent question, ma'am. I would just like to be really brief about this. So when we do a full night, we are actually making sure that the patient gets some REM sleep and in supine position, in which the apnea and hypoapneas are definitely going to be much more. In split night, sometimes we do not get adequate REM sleep, and hence it may actually be an underestimation of the severity of the disease.
Yeah, agreed completely.
Very nice, Shivani. Split night protocol is a comfort protocol. Kaide say it should be a 2-night work because it is laborious. It has been made to split. If you want a full diagnosis, a full PSG full night, and the full titration full night, but practically it is not possible. So it is a split night. But so many events you miss when you are not doing a full night protocol.
Absolutely. I so agree with Shivani and Dr. Chawla. I actually never get a split night study done. I mean, I just don't like it because the thing is that patients don't even go into proper REM sleep. And ideally, you require minimum 4 hours of sleep to even evaluate that sleep study. So I would basically say that don't try to save money of the patient because you're not giving them a report which is actually reliable. And therefore, your decisions also may be wrong. So I would be totally against it. I'm just getting so confused about what questions to take actually.
Amita, we close now?
Yes, sir. I think we should close. I just want to say a huge big thank you to all our pulmonologist friends, across India for supporting us so much. We've had 2,600 and I don't know, some 60 logins. We've had 277 questions. We still have 2,600 people plus logged in. I think the module has been super successful thanks to the fantastic faculty. All my 5 colleagues have been absolutely brilliant. They have taught me so much about sleep medicine. I have become a wiser woman today. I'm so grateful to each and every audience of ours. I know most of you all You all are more accomplished, more knowledgeable than I am. And thank you so much for still logging in and encouraging us and asking us questions and making feel important. I would just request each of our faculty to just say one line about treatment of OSA of your choice, just 1 or 2 lines, starting with Dr. Tampi.
Yeah, as far as the treatment aspect is concerned, I think the high index of suspicion is what I would probably say, that you should suspect that, particularly like Dr. Chawla brought out, we had a reference from a cardiologist who had recurrent patient being admitted for repeated admission for heart failure. I mean, and it was referred. And so we thought about OSA, we did a PSG and found that he had severe obstructive sleep apnea, and it was corrected with the CPAP. So my emphasis would be a high index of suspicion in these kind of patients.
Wonderful. Dr. Chawla?
Message to all is sleep medicine is a wonderful specialty. Please keep it clean. You practice, you will enjoy. Give time to the patients and listen their beautiful stories. You will enjoy and you will be giving back to them. Don't fall prey to the practices which are done by these companies. Thank you.
Wonderfully said, sir. From the heart. Dr. Nithya, what would you like to tell us?
Sleep practice, as Sir said, it's a wonderful specialty. And this, we should identify certain phenotypes of OSA. And it is now it's almost like a time for patient-tailored therapy in OSA. So in the future, we'll be seeing the phenotype of the patient and deciding on what phenotype will suit what treatment will be suiting for each patient. Maybe the future is that.
Fantastic. In fact, there was a question that based on phenotype, what is the future of treatment of OSA? We could not come to it, So everybody, we're going to have physical 5 workshops. Please come for it. We're going to answer all your questions. Shivani, over to you. What would you like to?
Yes, ma'am. So I think I would just like to add that manual titration is extremely important, and that's going to go a long way in improving compliance for each and every patient. So spending time and doing manual titration.
Wonderful. Shyam, what would you like to say?
My thing is like how we patiently explain inhalers to the patient. You need to explain the machine and the initial difficulties, what they're going to have, and explain the learning curve they're going to have in the next couple of weeks, and tell them it's all going to be fine. And, there are a lot of patients who say that the initial 2-3 weeks were tough, but then now they can't sleep without the CPAP machine. They're so I give them the specs analogy, where initially it always feels irritable and then later you can't do without it. So that's my message.
They will sleep without wife, not without CPAP.
Absolutely, sir. Absolutely. Very well said.
They want a CPAP. They are so much addicted. They don't want a wife. CPAP should be there.
I would just like to tell everybody that sleep disorders are so very prevalent, and patients with respiratory diseases are really frustrated because of their cough, because of their breathlessness, and a little bit of good quality of sleep can actually make them get so much better. They will heal spiritually, they will heal physically, and they will heal function-wise. And therefore, please keep a high degree of suspicion of every possible sleep disorder in every possible respiratory patient of yours, whether it is ILD, whether it is COPD, whether it is asthma. They all have a high chance of getting sleep apnea. And you identify and treat the sleep apnea, and believe me, the underlying respiratory condition will improve. And with this, a huge big thank you again to all our very accomplished, brilliant faculty, Dr. Chawla, Dr. Tampi, Dr. Nithya, Shivani, and Shyam. Again, happy birthday, Shyam. I was just going through, there's 100 people who wished you happy birthday. And a big thank you to Indian Chess Society for this fantastic initiative. And thank you so much, Team Sipla, Hitesh, Bijal, for supporting us. And a huge big thank you to all our colleagues across India. We love you and we are so grateful to you. Thank you and good night.
Thank you.